Good evening.
Can you see the video? I think.
Yeah, perfect.
Yeah, we can see.
Great, great. So now I'm all right. I think I'll stop sharing.
Good evening, Dr. Bakshi.
Good evening, Anup. How are you? How are the preparations going on?
Yeah, sir, everything is good. Because of your support, everything is going good, sir. Yeah.
It looks a great program. The whole program, right? We look forward to it on the 31st.
So I'm going to share, sir, my screen just to test the video. Can I do that, sir?
Dr. Noob, good morning, good afternoon, and good evening now. Dr. Noob.
Good evening, sir. Good evening, sir. Good evening. कैसे सर?
आपका ईमेल जो है
हाँ सर
हमारा PGI-MER के नाम से वो फिर डिपार्टमेंट को भेजता है।
अच्छा अच्छा
आपके किसी बंदे को बोला होगा ना आपने, तो उसे PGI का कोई ईमेल लगा के खोल के दे दिया, फिर वहां से मेरे को फॉरवर्ड किया डिपार्टमेंट वाले को, डिपार्टमेंट वाले ने मेरे को दिया। और कैसे हैं?
बस सर बढ़िया सर, आपका आर्टिकल पढ़ा, बहुत बढ़िया, कांग्रेचुलेशन सर।
थैंक यू जी। हाँ, दोनों टेक्निक निकाल दिया, वो दोनों लेक्चर तो देते रह गए, बोली दुनिया वाले को मिलेगा ना, कहीं कोविड में क्या हो जाए पता नहीं, एक बना तो दो कि कर क्या रहे थे। या
सर, आई एम शेयरिंग माय स्क्रीन सर, कैन यू सी दैट?
हाँ हाँ, एकदम अच्छा नजर आ रहा है, वेरी गुड। यस यस,
एक बार सर वो वीडियो चला के दिखा सर, वीडियो कैसे चल रहा है एक बार देख लेते हैं।
हाँ अच्छा, ये तो बड़ा क्लियरिटी, वेरी गुड है, बहुत अच्छा है। अब एक बार चला के दिखाइए। हाँ वेरी गुड। कल चूंकि आप नहीं थे ना, तो कल कुछ लोगों का ब्लड आ रहे थे
सर,
तो पता नहीं चल रहा था कैसे करना चाहिए। वेरी नाइस, ओके, दैट्स गुड। ठीक है जी, वेरी गुड क्लैरिटी। नहीं, अच्छा क्लैरिटी है, वेरी गुड वेरी गुड वेरी गुड क्लैरिटी। या इट विल शो एवरीथिंग देन। या राइट।
सर मैं वॉइस ओवर किया है, कैन आई शेयर माय स्क्रीन टू चेक द वॉइस कैसे आ रहा है?
हाँ करिए ना। यस हाँ आ गया।
इज इट हर्ड?
हाँ आपका सुनाई पड़ रहा, अभी आवाज नहीं आ रही, वीडियो वाली नहीं आ रही है।
वीडियो से नहीं आ रहा है
ना,
वीडियो नहीं आ रहा है सर?
नहीं हमारी थोड़ी सी आ रही है, आवाज थोड़ी कम है। गुड आफ्टरनून डॉक्टर सबनीस।
हाँ गुड आफ्टरनून।
गुड आफ्टरनून डॉक्टर हेमंत।
थोड़ी सी बढ़ानी पड़ेगी आवाज।
हाँ यानी तो आप खुद अपना बोलना पड़ेगा।
वीडियो का ऑडियो इज नॉट प्रॉपर।
हाँ डॉक्टर रवि, लगता है वो ऑडिबल नहीं हो पाएगा, तो मे बी आप अपना देख ले, दोबारा एक बार करके दिखाइए।
You fill the bladder with 50 to 100 ml surgery. With that thing in mind, I'm going to share a video presentation of our experience of robotic BBL, the standard way and the complex.
अभी ठीक है,
अभी ठीक है।
आप देखो कि क्या बात है, आपका कोई प्रॉब्लम होगा। Now it is heard.
ओके सर, मेरे ख्याल से सर सब म्यूट में जाएंगे तो it would be heard better.
हाँ करेक्ट करेक्ट, बढ़िया हो गया। So let me share my screen.
Good evening, everybody. Can I share my this? I probably in the list.
हाँ जी है, टाइम तो है।
Good evening, Anand sir. Good evening, Rajiv.
Good evening,
sir.
Good afternoon, everybody. Dr. Chawla.
And Shravan sir. Yeah. Good evening, Dr. Amlesh.
Good evening, everybody. Good evening.
Good evening, sir. Good evening.
Dr. Amlesh, hi.
Hello. Hello, everybody. Good evening, sir. Good evening.
Good.
Good evening. How are you?
Good afternoon, sir. Good evening. Right. Fine, sir.
We're fine, sir.
Good evening, Arvind and Rishi. Good evening.
Good evening, sir.
Everybody.
Good evening, sir.
Right.
Good evening, sir.
Very nice. Yes. Yeah, on time. That's good.
I'm not getting my screen for sharing, so I would just log out and re-log in.
Yes, I am also not getting.
So I will just.
Hi, Dr. Ansari.
Hi, sir.
Yes.
I will just also try to log in again. इसमें नवनीत will have to make them co-host, no?
I think Navneet has already made all of us co-hosts. That is why we are able to speak and talk to each other.
Unless you become co-host in this setting.
Sir, I have already given the permission to share, sir, to all the faculty, sir, today.
Okay, all right.
Yes, sir.
That's okay.
Good, Navneet.
हमारी ड्यूटी है तो एक घंटे बाद हमको बता फिर उसके घंटे ठीक आ रहे ठीक
ऐसे लेवल वाले आपसे अभी वो कराया 105 पहुंच गया है ये उसका प्रिस्क्रिप्शन
उसको भेजो हमको
किनको
हमको
ठीक है
उनको भेज दो हम जवाब दे देंगे उसको और उसका
हाँ डॉक्टर अनंत हाँ डॉक्टर अनंत कुछ बाहर कुछ सजेशन दे रहे हैं लगता है इंस्ट्रक्शन हाँ सर
गुड इवनिंग सर अनंत सर
हाँ
अरे अनंत सर 2 सर्जरी के बीच में है भाई
उनको मैंने बोला हाँ नोट कर लो तब बोलो
and Seth sir is also good evening sir
good evening everybody good evening
sir actually Dr. Anant is I think
Dr. Rajiv
hello how are you
Dr. Rajiv
fine, Dr. Rajiv all of us very good
yeah
but Dr. Rajiv you are looking the most fresh person
राजीव टीपी
yes
राजीव बहुत है यूरोलॉजी में
गुड इवनिंग डॉक्टर राजीव
डॉक्टर राजीव सूद इज आल्सो देयर ये बड़ा अच्छा है ना डॉक्टर राजीव गुड इवनिंग बोल दो तो आधे लोग कवर हो जाएंगे
जब सिर्फ राजीव बोलते हैं तो दोनों को कॉम्प्लीमेंट मिल जाता है
दोनों को मिल जाता है हमारे यहाँ एक बार इतने सारे राजीव थे राजीव सूद राजीव कुमार राजीव गोयल राजीव यादव राजीव और भी 5 मतलब at one time and we had 2 Rajiv Suds not only one we had 2 Rajiv Suds
and I used to sit in his room only after he left and people thought my face is changed शक्ल बदल गई
प्लास्टिक सर्जरी करवा के
प्लास्टिक सर्जरी कर दिया लगता है
another Sood is in RV sir
yeah
yes he also did MCH from All India Institute
from All India Institute
hello Amlesh
Dr. Rawal has also joined
how are you
गुड इवनिंग सर
evening everybody so if you come through YouTube you cannot communicate
you come through YouTube you can only watch
you can just chat you can send message only you can send message not chat
but faculty cannot participate from YouTube
will be difficult you can't do that there you are on YouTube yes being recorded
मैं एक मूवी में देख रहा हूँ बस मैं कुछ देख रहा हूँ टीवी में तो
वाला म्यूजिक है
उसका ऋषि का बच्चा बोल रहा है
अरे आनंद कुमार सर ऐसा लगता है कि आप खड़े हो भाई
खड़े नहीं हम बैठे हुए
आप उनका नहीं सर उनकी ऊंचाई ऐसे ही है सर हाँ ये दीवार के बराबर छत पर चढ़ कर रहे हैं एकदम
मेरा पोजीशन ऐसा लगा कि भाई आप खड़े हो
इधर विंडो है अगर ऐसे मेज पे रखे ना तो भी ये डार्क हो जाता है इफ यू फेस द विंडो
तो ये इसको अपने लैप पे रख लेते हैं, लैपटॉप को गाड़ी अपने चेयर घुमा दी और उस पे रखो तो ये विंडो इस तरफ से लाइट इधर से आ रही है ना।
सही बात है।
ये मोबाइल पे होगा ना सर, इसीलिए थोड़ा सा ऐसे नीचे से आ रहा है लाइट।
नहीं मोबाइल नहीं, लैपटॉप है।
अच्छा,
तो आप ऐसे कर लो, ऐसे कर लो, कैसे कर लो,
अभी
ऐसे कर
बराबर,
लो।
अभी बराबर लग रहा था। पहले ऐसा लगा था कि भाई खड़े हो गए।
नहीं
ऐसा लगा कि जैसे सर्जरी में जा रहे हैं अभी छोड़ के हमको।
नहीं अभी नहीं, हम आ गए यहाँ से, अभी खोल करके गाड़ी में बैठ जाएंगे, फिर घर पहुंचेंगे तब तो घर में
ये सब किस्सा कुर्सी का
अभी
है।
अभी हाँ, डॉक्टर प्रांजल आ गए, ही इज हियर, डॉक्टर प्रांजल इज ऑलरेडी हियर, यस। अभी डॉक्टर राजीव टीपी आ गए, वो भी हैं।
Sir, good evening everyone.
अरुण
Dr.
चावला भी
Prasoon
हैं,
Ghosh.
that's good, so we can start now.
1 मिनट बाकी है,
Another 1 minute to go. Okay, Prasoon.
Good evening everyone, sir.
good evening.
Evening.
Good evening.
Yes. Good evening, everyone. Respected President Urological Society of India, Dr. Anand Kumar, Chairman Indian School of Urology, Dr. Rajiv Sood, eminent faculties for today's webinar. I welcome you all to this important webinar on robotic urologic surgery. We have got an esteemed panel of faculties who are really experts in the field of robotic urology. In India, I think robotic urology has taken over everything from the laparoscopic urology. And today we will have all the experts displaying their techniques in various aspects of the urologic surgery. I welcome again the viewers from Urological Society of India as well as from our countries to this webinar. With this few words, I welcome you once again. Now I request the President Urological Society of India, Professor Anand Kumar, to give his address. Over to you, sir.
It is 5:30 now.
I think Chawla, can you unmute yourself? Good evening everybody, and I think this is a very important webinar. This is very true. Robotic surgery has taken very well in India. Now we have around 78 robots in the country, and some of the centers have 2 robots. So they are so busy, they have to put another robots to keep their load be taken care of. And it's not only developed in urology. We have excellent robotic surgeon in gynecology and ENT and thoracic surgery and abdominal surgery and oncological surgery, gastrointestinal surgery. And even in robotic surgery in urology, almost all kinds of operations are done, whether it is a reconstructive urology, whether it is oncological procedures, or and this is also tribute to us that robotic surgery, robotic kidney transplant has taken shape in India. Dr. Alawat has started and Pranjal Modi has now tremendous experience. I think many centers of Europe together may not match his experience. And we have a very good robotic and all surgeries are done, whether it is radical prostate, and all the variants of radical prostatectomy is being done very efficiently, whether it is radial sparing or various other procedure, radical cystectomy, no bladder reconstruction, partial nephrectomies, all are done very well, and we have seen in various webinars, and our surgeons are so good, it is treat to watch them. And I think this webinar will help us, the younger generation, to learn more about the robotic surgery, get motivated to undergo proper training, and so that they can also become a robotic surgeon in future. And at the same time, I would like, as a president of USI, I would like to pray for the good health of all our members, their loved ones, their families. And I wish you all should remain healthy, stay safe, and don't lower your guard, so that you can keep serving the humanity and remain fit. And With this, I welcome you all for this wonderful webinar on robotic surgery. And it is back to Dr. Sobuda, Dr. Chawla, whoever is going to speak. Thank you.
Thank you, sir, for your enlightening words. Now I request Professor Ajit Sood, Chairman ISU, to give his address.
Thank you, Rajiv. Dr. Anant Kumar, Dr. Chawla, my co-chairman with me, and all the eminent faculty for this robotic webinar. I retrace the days when first robotic workshop was held in India, and I was fortunate to provide out of the 4 patients in that workshop in Delhi, and that was conducted by Dr. Vipul Patel, and I remember that day, the same time, the history was made when the Dr. Alok, Dr. Hemal and Dr. NP Gupta also did the robotic surgery, radical prostatectomy in All India Institute, and later on they will be awarded with the Padam Shri Awards. Thereafter, the journey started, and in urology, various workshops were held and very successful. The renal transplant program, Dr. Alawat, Dr. Anant Kumar later, and so many people, it is difficult to name everybody. And lately, I think Dr. Sudhir Raval is making records in robotic surgery. We in Indian School of Urology thought that there should be the programs, the training programs, and also in Ramaiah Institute, the robotic training programs on cadaveric robotic training programs. I had gone there, I have undergone the training, and also I planned that how it is to be executed in the Euromet of Indian School of Urology. And then suddenly this COVID problem started. So we are in the process of organizing and that program. Lately in that cadaveric program, the cadavers are not available, and also the cadaver donation is stopped for the time being. I talked to Dr. Ramesh. I wish all of you to enjoy this integration of the skill exchange, and also the development and evolution has gone to such an extent that we are doing very fine surgery. I remember 2 years back when I was president of Urological Society of India, I visited Belgium, and Dr. Tomball's place, he wanted to show that how precise you can do and the robotic surgery. And they made the one of their colleague, he was sitting in the room, and the robot was doing the shaving, and it was beautiful shaving done. So it is so accurate, so well magnified view, and also so comfortable for the person. So more and more people, maybe more than many other countries, in India, robotic surgery is adopted, and we have world-class experts in India as well as making name all over the world. And therefore, it is very important that after our laparoscopy, ultrasound, and other webinars for general urology, we will consider it today that this is minimal invasive urology, but also robot has entered the arena of urological surgery. This is the best example of integration of technology, ever evolving technology, and the surgical skills. So wish all of you all the best for this webinar. And once again, like last 2 times, the time management was very perfect, and therefore I request all the speakers also to stick to the time, and so that the interest generated all over the world on this. I am sure that there are going to be a lot of people who are going to watch this program, and all the best to the organizers, and also the faculty, including Dr. Pranjal Modi. Thank you.
Thank you, sir. Thank you very much. Now I request Pranjal Modi to take over the session. Over to you, Pranjal.
Yeah, thank you very much, Rajiv. Thank you for the opportunity and welcome to all the faculties over here. I had an opportunity to talk to Dr. Mani Menon several years back. How did you jump into the robotic surgery? And he shared that yes, that it was started in France in 1990. He could not do the laparoscopic surgery. Dr. Jyly was doing a lot of laparoscopic surgery, and then he wanted to do something new. His wife encouraged him to do something new. And then in 2000, he started with the French surgeon, he started doing robotic radical prostatectomy. In 2001, in AUA, there was a battle going on. Patrick Walsh for the open prostatectomy, Jyly for laparoscopic surgery, and Dr. Menon for robotic surgery. And finally, in the rebuttal part, it was just Dr. Menon told one line, that train has already left. Those who are watching, let them watch. And exactly that has happened 10 years down the line, 15 years down the line. Now what you see is everywhere there is a robotic surgery. So with this brief introduction, and the aim of this particular meeting is very clear, is that robotic surgery is the present and it is going to be the future. So with this, may I request the chairperson of the first session, Dr. S.K. Singh and Dr. Amlesh Seth, to take it over and invite the speakers. Thank you, sir.
Yeah, thank you, Dr. Pranjal and all the faculty members. I think opening batsman is Dr. Ravi Mohan. Yeah, we have got, yeah.
Thank you. Am I
Pranjal,
audible?
yes. Yeah, you are audible, Dr. Ravi. So we have got a session, 3 sessions, one on reconstructive oncology, second purely oncology, and third is on kidney transplantation. So the time allotted is 10 minutes. Maybe as maybe if the time permits, we can have some query and question from the faculty so that the audience can listen to this. And then we will make some 1 and 2 comments, smart comment. So now to Dr. Ravi Mohan. He's additional professor at the Department of Urology and is a robotic surgeon at the PGI. So let him start now. The robotic baby repair. Dr. Ravi Mohan, please.
Thank you, sir. Thank you, USI, ISU, and Pranjal, sir, for this opportunity. And thank you, Singh, sir, for those kind words. I am a robotic surgeon because of you. So this is a video presentation. I'll play the
next
video.
Level of evolution of robotic surgery is reconstructive surgery. With that theme in mind, I'm going to share a video presentation of our experience of robotic BBF, the standard way and the snippets of complex BBF. Conventionally, larger supradiagonal fistulas are managed by open Punners repair. Lab has bridged that gap to some extent. However, precise dissection and ease of suturing makes robotic approach the preferred one. First step is cystoscopy, identification of fistula, identification of the orifices, and placing a ureteric catheter across the fistula. All the surgeries, these are done under pelvic docking with 3 or 4 arms. Typically, you would always find adhesions. So first step is adhesionolysis because these are redo surgeries. And then once you've done that, you fill the bladder with 50 to 100 ml of saline. So at that, you make a small transverse cystotomy. This is aided by tugging of the ureteric catheter which is placed across the fistula so that you open the bladder very close to the fistula. Here you can see a small cystotomy being made and you see 2 infant feeding tubes. That means there are 2 fistulas. And then you can also see the ureteric catheter which is placed in one of the left ureteric orifices. So the first step is separation of the fistula from the bladder. Here you do with a sharp cutting to ensure that the vascularity is well maintained. No cautery is being used here. Once adequate flaps are made, about 1 centimeter on either side, the vagina is closed. One can freshen the margins if required. So you close the vagina using 2-0 Vicryl. Then one can use appendices epiploicy or the omentum, whichever is readily available, to close over the vagina. so that there's a bridge between the bladder and the vagina. And then the bladder is closed in a longitudinal manner using a V-lock suture. One can freshen the margins if required to ensure a thick bladder flaps. So these are the standard principles how an open surgery was done, and this is what can be replicated in robotic surgery to prevent recurrence. Another way is to do a transverse cystotomy. Again, same technique. You would make a small transverse cystotomy. You can identify the fistula, ureteric catheter across it. Then using a sharp dissection, you create the plane between the vagina and the fistula and the bladder. Freshen the fistula and close the vagina. This technique ensures that both the bladder and the vaginal mucosa, they move farther apart, because the bladder is also closed transversely and vagina is also closed transversely, and one can place a sigmoid epiploic as an intervening area. So this is a preferred technique, a very good simple technique. Typically takes 25 minutes maximum in a simple fistula. But if a fistula is going transtrigonally, then probably this technique may not be feasible to do. This is very good for a large supradragonal fistula. So the bladder is closed. See how well the suture lines are spared apart. Now these are the initial series which was published in International Urogynecology Journal of 30 cases. Now some snippets of complex VVF repairs. A fistula which is more than 3 centimeters, radiation fistula, close to bladder neck, redo fistula, these are complex. So one vesico-cervico-vaginal fistula. You can see the uterus and the bladder. Again, a small cystotomy is made. Appreciate that the vaginal flaps are being made, the large supradragonal fistula, and to prevent air leak, a gauze piece is being packed in the vagina. And see how close it's closer to the bladder neck. This is the torn vagina which is being repaired. And once the cervix is repaired, the vagina is closed. This is followed by closure of the bladder. This patient had regained normal menstruation after 3 months. And vaginal incorporation, another unique technique which was done robotically. Here you can see the right ureteric orifice. The left orifice is not seen. And as we give phenazophyridine, we saw the efflux coming through the fistula, confirming that it is opening into the vagina. We put a ureteric catheter. And after cystotomy, a typical incision would have meant an incision like that, requiring ureteric reimplantation. However, what we did, we created vaginal flaps a little farther away. And as we reached close to the ureteric site, orifice, we changed the flap in this direction, thereby ensuring that the vagina is incorporated into the bladder suture line and omitting the need of performing a ureteric reimplantation. And the vagina is closed. At 3 months cystoscopy, we found that the vagina was nicely incorporated into the vagina, and you cannot really differentiate between bladder and the vagina from cystoscopy. So once the vagina is closed, the bladder is again closed transversely. This further ensures that two suture lines are moved apart. As you do this, there's a little tension on the bladder walls, so you can appreciate that. So bladder can be dropped down, which is just a 5 minutes job for all the robotic surgeons who are performing prostatectomies and cystectomies. And now you can see there is hardly any tension on the bladder suture line. So the cystectomy is completed, then we do a leak test to confirm that there is no leak, and then the omentum is placed. Now VVF with the ovary flap. Unfortunately, I don't have a video. What we did is we used the same one of the margin of fistula and created a ovary flap out of it and re-implanted. This is a picturesque representation. So far, we have done 78 BVF repair, out of which 33 are complex BVFs. And this is the data sheet of that. This was accepted in Urology Gold Journal. These are our further publications on BVF. So cystoscope is must. Use of ureteric catheter of different colors. Intermittent taking of catheter ensures a small cystotomy. Sharp dissection to prevent ischemia, and interposition whenever feasible. I would say robotic assisted BVF is safe and feasible and provide advantages of minimal invasive surgery. Thank you.
Thank you, sir. Dr. Ravi. We have got another 1-2 minutes. So maybe any of the, our faculty, they can have some query. But yeah, Dr. Ravi, you have made a point that most of the time you spare to use your cautery until unless there is a spurter.
Right, sir.
Right. So what is the idea?
So the idea is to avoid ischemia to this to the bladder and vagina, because to ensure good healing, you need a healthy vascularized tissue, and that is the reason that you try to do sharp cut without using cautery as much as possible. Allow those small bleeding to happen. This ooze is not a problem to manage. So that's probably a very important thing which should be remembered, because in a robotic view, even those small bleeders will look too big, and sometimes it seems you want to have a very clear field, and then you end up with the ischemic tissue. I did not cover the vaginal part of BVF.
Okay, so ischemia, right? Okay, right.
Yeah. I think the vaginal part, transvaginal repair, there are good proponents of that, and it is one technique. Robotic is another technique where which is there as a versatile armamentarium, that you have a very high fistula, you have to do ureteric implant, you have a very narrow vagina. All those, even those things can be encompassed in a robotic repair. That's
right. Sorry to interrupt you again. Now, a very small comment we want from you. Yes, when you made initial cystotomy, because people will be thinking where to make a small cystotomy, because you don't want to create ischemia or don't want a big cystotomy. So how to judge where to make the cystotomy, initial cystotomy? What are the points which you have, or tips which you like to again share with us for making a small cystotomy? To start with where?
Yes, so in the video you would have seen that we would have done a cystoscopy and placed a ureteric catheter or an infant feeding tube across the fistula which comes from the bladder into the vagina. And then that can be tugged. So that tug ensures, that tells you where is the actual fistula site. That is your cystotomy site. And you would tend to fill the bladder with about 50 to 100 cc saline, so that you have a distended bladder, and that is where you make a cystotomy to ensure that even the posterior wall doesn't get injured in that process.
Okay, thank you, Dr.
I would like to make a comment regarding the vaginal flap, which avoids ureteric reimplantation. Almost 10 years ago, we had published this technique in International Journal of Urogynecology, and I have also presented a paper in one of the SIU conferences on use of vaginal flaps. We had done all these surgeries transvaginally, but I'm sure that if we use the robot for doing this transvaginal surgery, the transvaginal surgery will become easier, because with a good retraction, good vision, very close vision, and manipulation in those tiny areas, with the robot, it will be easier to do transvaginal surgery also. Obviously, the cost is going to be significantly higher. And the struggle that we have of doing vaginal surgery, most of us can do it, but I'm sure our struggle will come down with the robot.
Right. So we can now ask Dr. Rishi Nair to please present your video.
Thank you, sir.
Thank you, sir.
Thank you. Thank you, Dr. Ravi. Thank you very much.
Are you getting my screen, sir? Hello? Am I audible?
Yes, you are audible, and your screen is also seen.
Okay, so good evening to all the teachers and colleagues and all the viewers on the net. And a special thanks for Dr. Pranjal for having invited me in this program. Now I am going to present basically on a robotic bladder diverticulectomy, which is actually a simpler technique, can be done laparoscopic way, open way also. But nonetheless, I am going to present one such case to you. So here was a 39-year-old male who presented to us with the history of about 3 months with low urinary tract symptoms, both straining and irritative symptoms were there. But he presented because of a recent hematuria one episode 5 days ago, and he took treatment at a local center somewhere, and it's immediately subsided after antibiotics. He came with an ultrasound which showed a large bladder diverticulum and high post-void residual urine. Urine routine at presentation to us was normal. So based on this, we did a RGU and MCU study, which clearly showed that there was a large bladder diverticulum towards the right side of the bladder, and the capacity of the diverticulum was actually more than the bladder, and the uroflow obviously was slow. The patient was voiding probably into the diverticulum. So a CT scan was done, which confirmed the presence of a stone in the diverticulum, and the diverticulum was very large, and a very narrow neck of the diverticulum could be seen in one of the area, and there was a significant non-dependent part of the diverticulum also, which was below the neck level. So the approaches for diverticulum excision are the endoscopic incision of the neck, or the complete diverticulectomy can be done by either extraperitoneal or transperitoneal approach, and more recently robotic transvesical diverticulectomy has also been described. However, this transvesical diverticulectomy is usually feasible only in cases where the neck is relatively broad and the diverticulum is not too deep or too large. So we decided on doing a transperitoneal diverticulectomy in this patient. Now, whenever this diverticulectomy is done, there are a few points which must be kept in mind for achieving success in the case. One should not rush in for surgery. One should only operate about 2 to 4 weeks later, depending upon how severe the diverticulitis was in a patient. And as for any other surgery, it is obviously important to keenly observe the alterations in the anatomy that has happened in the patient on pre-op imaging. These structures which are important in this particular region are obviously the ureter, vas, and seminal vesicles. In this patient, the right ureter was pulled medially, and it was located in between the diverticulum and the bladder itself. And then the rectum also is closely abutted to the large diverticulum, and we have to be careful during the resection of this. And finally, a pre-op cystoscopy is very important in such cases, because we have to see the exact details of the diverticular neck and what is its relation to the ureteric orifice inside. And because this orifice may be, the anatomy is changed, it is important that one gives some kind of a coloring agent to the urine. We used pyridium in this patient to identify the ureteric orifice. And if necessary, a stent can be placed. We also place, as I would show in the video subsequently. And we also place the catheter directly into the diverticulum by passing the catheter over a guide wire during the cystoscopy. This actually helps in identifying the diverticulum. In one such case with Dr. Himmel about a decade back, we had this difficulty in identifying the diverticulum, where the diverticulum itself was collapsed and not very large. So after that, we have always been placing the catheter directly into the diverticulum. So this was the case. We proceeded with cystoscopy. The urethra and bladder neck were all normal. The coloration of the pyridium could not be cleared because of the diverticulum could not be completely flushed out with irrigation. So initially we struggled to find the right ureteric orifice. Only bullous edema could be seen for 4 or 5 minutes, but once the bladder distended, we could see the diverticular neck also, and then the pyridium helped us identify the ureteric orifice, which was shifted somewhat in the midline. And it was about 1.5 centimeter below the diverticular neck, and we could see the stone also in the diverticulum. And we placed the ureteric catheter, which would be removed subsequently at the end of surgery. And then we placed the guide wire into the diverticular neck, and over it we passed the catheter, and we inflated it with 20 cc balloon. So we used 4 ports. The fourth port is optional, and 1 assistant port was used. The port configuration is more or less similar to any pelvic surgery. This was the course of the ureter, the vas, and parallel to the vas, we gave the incision. And here you can see the Foley's bulb inside the diverticulum, which helps to actually identify the diverticular wall. If it is collapsed, it becomes very difficult to identify what is what. So after that, we just go on isolating and dissecting out the diverticulum all around. In such a large diverticulum, there may be formation of a sort of a pseudo capsule. So we just keep the sharp dissection all around along with blunt dissection, and we sort out all the planes. Here you can see this sort of a pseudo capsule forming. So posteriorly, it is the rectum is important because it gets pulled up. You can see the mesorectal fat and the rectum getting pulled up as a sort of a pseudo capsule. So the wall itself gets thinned out. So here was the superior vesical pedicle and some of minor branches which was going directly into the diverticulum. Diverticulum has been dissected on the lateral side and the posterior side first, and from here we would go to the medial side because all the structures, important structures, were more on the medial side and rectum was posterior. So all around it has been dissected. Some feeders were found on from the lateral pelvic wall also. They were also cauterized and cut. Anteriorly, it is easier to dissect out the diverticulum all around. And finally, we came to the medial side. Some small branches from the superior vesical artery were fulgurated. And after the ureter was kept medially all along. So one large feeder vessel was also seen from the superior vesical pedicle, and here you can see the seminal vesicle also coming into the view. This feeder was then ligated with clip and cut close to the diverticulum. The main pedicle was kept intact so as not to cause the bladder ischemia and cause the subsequent neurovesical dysfunction. So finally, this is the bladder neck, which was isolated. Here it is important not to stretch too far so that one doesn't end up cutting inside the bladder, and also not to leave some of the diverticular tissue because diverticular tissue may not have a backing of detrusor. And therefore, if you leave some part of the diverticulum, one may end up having a small diverticulum again, which may again gradually balloon out. So subsequently, the only thing remaining is closure of the cystotomy. If one thinks that the bladder wall is thin, a second layer of detrusor can also be used. But in this case, we use only a single layer. And subsequently, the peritoneum has to be closed and drain is to be put. We keep the catheter for about a week. The specimen is retrieved in we generally use a homemade retrieval bag. So this was the specimen which was removed along with the stone. And we actually published our technique of doing this diverticulectomy in 2007 with Dr. Himmel. We did 3 cases at that time, and subsequently I have done 3 more cases. One case actually not diverticulectomy. I used the diverticulum for augmenting the bladder as a diverticulocystoplasty. So finally, I would say just it is important to read the pre-op imaging and do a pre-op cystoscopy in all these cases. And don't leave the patient as such. This patient still needs follow for a neurovesical dysfunction. Thank you.
Thank you, Dr. Rishi. Now, when you are dissecting posteriorly, anteriorly, laterally fine, and you are now thinking that you may not injure the rectum, is it worth that you open the diverticulum that time so that you feel safe from rectum side dissection?
Sir, if diverticulum is in hand, we have already isolated. We know the diverticulum wall as such. Otherwise, if the diverticulum is not, or there are too much of adhesions, then maybe yes, definitely only the mucosa can be removed.
From the rectum side.
It's not necessary to remove the muscular wall.
Okay, thank you, Dr. C. Thank you very much. Now we can move to Dr. Ansari. as has been told repeatedly by Dr. Pranjal, time allotted 8 minutes, we can take up to 10 minutes. So, okay, I think just maybe at the end, if you have some time, we can discuss something about.
I'm audible, sir?
Yeah, Dr. Ansari, yes.
Yes.
Yeah, yes, waiting to listen to you.
So, the picture is also visible, sir? Screen share? You're getting my slide, sir?
Yeah, we can see the slide, Dr. Ansari.
Okay. So, the urinary diversion along with the catheterizable channels, they play a central role in diversion in cases of many disorders of lower urinary tract, especially in neurogenic bladder as well as in bladder dysfunctions, other varieties of bladder dysfunction, especially in bladder bowel dysfunctions these days. And the advantage of robotic is that it provides all the advantages of minimal invasive surgery. It can also take the challenges which are usually encountered during laparoscopy. So this is about the appendicovesicostomy in a 5-year-old child for dysfunctional voiding, and he was not able to catheterize or empty his bladder. So this was the position of the child, which was a dorsal lithotomy with slight 10-degree tilt at the head. And the child is properly cushioned and all the pressure, and even the surface is also covered with electric blanket. And this is the scheme of the port placement. They are the two landmarks which need to be remembered, is the two mid-clavicle lines here and the umbilicus. The first port is to be kept above the umbilicus. This is a 12mm port for camera, and the two instrument ports are kept along the mid-clavicle lines. And this is the additional port for the application of robotic small bowel clamp. And this is for the assistant port. This is optional, but this is quite useful. And during the procedure, I will be telling where it is useful while you are doing anastomosis. So the procedure basically begins with the isolation of the appendix. We need a healthy appendix with good vascularity, and most of the time in pediatric population, the appendix is quite long and healthy, and you can see the pulsation also. And the harvesting of the appendix begins with creation of a optimum size of the window with caring for the pedicle of the appendix. You little bit enlarge it, and you can see the pedicle here. Then you go for appendicectomy. That conventionally begins with some soft scoring around the base of the appendix. If the appendix is short, you can take a cap of the cecum as well. So that can be used to cover the shortage of the length of the appendix. To give you small nicks, and wherever the bleeder comes, you can directly coagulate it with the endo shear as well. Here you stop here, and you do not sever it completely from the cecal wall, because this will be helpful. I will tell you how in subsequent steps. See here, because this will be used as the bowel retractor for traction. So that will help you in closing the cecal wound. Cecal wound is closed in 2 layers here. You can use vicryl suture or PDF, the way which, whatever you like, the 40 or 50, depending on the age of the child. and the second layer is closed with 3 or 4 or 6. Now you divide it here because now it has served its purpose for retraction and helping us in the anastomosis. Yes. Now appendix is completely dismantled. Although the appendix is usually long in children, but still there is no harm to make little more general dissection by dividing the posterior peritoneum here. That will give you additional length of the appendix and reach it to the bladder easily. Then you go for the detrusorotomy for creation of a trough to bury the appendix into the bladder. You create a small cystotomy into the mucosa. Now you prepare for the appendicular implant into the bladder. For this, what you did, you take one anchorage stitch so that the tip of the appendix is stitched to the bladder muscles. So during anastomosis, it does not twist, rotate. This is simply to fix it to the bladder wall. This is not going to do anything with the anastomosis of the appendix to the bladder wall. This will just keep it stable there so that it helps its anastomosis and the appendix does not rotate during anastomosis. Now you make an opening into the appendix on the posterior side so that this opening in the appendix that falls just opposite to the cystotomy. Here you begin with the anastomosis first on the lateral wall. And again, you can see the advantage of the robotic arm. It will keep you a constant traction of the area of the surgery. Because if you are using assistant, so he may be tired many times. You can see this is taught me clearly. Now, after completion of the lateral wall, now you are cannulating the appendix and putting this feeding tube across appendix into the bladder. That confirms that your anastomosis has not tangled the medial wall into it. It is passing from here and going into the bladder. This will stay here until the completion of the maturation of the stoma on the skin. Now you begin the medial wall anastomosis. Here, the advantage of cannulation of this is that you do not get confused between the medial and the lateral wall of the appendix, because the lumen of the appendix in children is very small. You can see the mucosal margin clearly. And these are all the advantages of the robot, which are usually difficult to find because in laparoscopy, such steps are so stressful. Now you proceed for the burying of appendix to the bladder wall. You can do detrusorotomy with interrupted stitches or continuous stitches. This is the choice of the surgeon, whichever way they want to do it. This is the completion of the detrusorotomy from here to here. Now you prepare the appendix to take it outside the abdomen. Now you confirm that there is no twist on the appendix, this pedicle. You take it out from the stoma. And there are two ways. Either if because the stroma is put on the predetermined site. If you have planned for right iliac fossa after discussion with the parents or the patient, then you take it out into the right iliac fossa, or you can take it out through the belly button. Here, the stroma has been made through the umbilicus in this child. And the choice basically depends the demand of the patient as well as the length of the appendix from where it has to come out. With this, I thank you all.
Amlesh. Yeah, thank you, Dr. Ansari. Thank you very much. Again,
thank you, Dr. Ansari.
Yes,
it's been a very good, obviously open surgically, a lot of these have been done for a long time. And I generally amputate the tip of the appendix when I have been doing it open surgically. I have not done it robotically. So how did you finally manage the tip of the appendix? You have to unmute yourself, Dr. Ansari. Dr. Ansari, you are mute.
So, sir, the tip has been used to put the anchoring suture, the first stitch to fix it to the bladder.
Yeah, so that tip will actually prevent the detrusor. So the tip has to be amputated obliquely.
But you usually doesn't cause any problem. All the cases which have been done this way, but that really helps. That does not allow the this appendix to twist. In open surgery, so you have so many control. But in laparoscopy or robotic surgery, the appendix keep rotating. So that creates problem in putting anastomosis, especially on the lateral wall.
Yeah.
And secondly, it avoids the traction on the appendix also. It keeps going back whenever you are taking stitches.
We can go next speaker, Dr. Amlesh.
Thank you so much, sir. I think Anand sir has arrived home, sir, now.
Yeah, good evening, sir. If I'm audible now, sir?
Yes. Yes, Dr. Anup, please.
You can see my screen, sir?
Yes.
Yeah, okay. So, good evening, everyone. I would like to thank USI, Indian School of Urology, Dr. Rajiv, Dr. Pranjal for giving this opportunity. I'm going to show you a transperitoneal robot-assisted partial nephrectomy step-by-step approach. So, this was a 70-year-old index patient with right flank pain for last 1 year. And on evaluation, the KFT was normal. And you can see this was a posterior halar tumor on the right side, 4.5 centimeter. And they was having 2 accessory arteries and single renal vein. So we planned this patient for robot-assisted right partial nephrectomy. The renal score was 10P and clinical stage was T1B and 0. So before I go to the surgery, it's very important for the young surgeons who are watching, we should have these instruments ready before you undertake this surgery. Robotic ports can be 3 or 4 as per the surgeon's choice. I use 4 if it is a complex case, otherwise I use 3 ports. If it is a obese patient, I use a bariatric port. Then a 12mm air seal port I use in a complex case. And then a 5mm disposable or a reusable assistant port is required. These are instruments typically use robotic scissors, bipolar fenestrated grasper. This is what I prefer, but you can also use Maryland forceps as per your choice. Needle driver is required and a progress for the 4th arm. Now I prefer lap bulldog, clamps and a plier. The another option is lap Satinsky. Now this again depends upon surgeon's choice to choice. Lap scissors is required, hemolock clip applier. Suction is very important. A good suction is must for this surgery. You should have 2O, 3O V-lock suture, 3O Weichel suture. I always keep a rescue stitch for any untoward vascular surgery during these kind of surgeries. And an endo catch bag is again can be endogenous or can be company made. The typical port configuration I used, this is the right side, all ports in one line because it's an XI system. As the patient becomes more obese, it shifts more laterally. This is my air seal port for the assistance, and this is the lever retractor port. So this small video, I'm going to show simple steps. So we start with the colonic mobilization. So now it's on the right side. So you have to mobilize the colon and the duodenal cochleation has to be done. so that you can have a very good access to the renal hilum. There is no need to mobilize ureters in all the patients. Very selected patient with a very big lower polar tumor, you might require to use the ureter as a anatomical landmark. Otherwise, most of the patient will just go directly to the hilum, as you can see right there. And that's the ureter. We have not touched that ureter, and we are going directly for the hilar area. So in the hilar area, then it's very important to dissect all the vessels. As I told, in this patient, there were two accessory arteries. So the first to encounter was the renal vein in the anterior part, and this is the one of the small accessory artery. So you have to dissect it, loop it properly. So the main aim of this surgery is you have to dissect the hilum very, very methodically. You have to clear every tissue above and below the hilum so that you should not miss any small accessory artery. Sometimes a good CT angio might also miss a small accessory artery. So I always make sure to dissect this hilum above and below. Nothing is left undissected. So now this is the renal vein being looped, and after this we'll go for the main renal artery. So invariably the renal artery, you can see it's behind the renal vein, and we are going to dissect it and loop it. After that we'll go for the second accessory artery. So this is, I think, step where you should devote more time, because this is the step which is going to decide your future outcome of the surgery. So this is the accessory artery, second one, which you're dissecting. As you can see, I'm using fenestrated bipolar. Some people might use a Maryland. That depends upon the choice to choice, but I prefer this instrument. After that, now you have to mobilize the kidney totally. As you can recapitulate, it is a posterior hilar tumor. You have to mobilize the kidney all around so that you can flip the kidney medially. This is very important, because unless you do like that, you are not able to do a good dissection and a good renography. So you can see I'm doing the mobilization of the kidney all around, and then we're going to flip it medially so that we can have a good access to the posterior hilar tumor. So you spend good time here, and this is the tumor right there. Now we always use the intraoperative Doppler in all the patients, irrespective of that it's exophytic or endophytic, and then we always mark it. This is our protocol, and we take a 1 millimeter margin all around this tumor, and after marking it, then most of the patient we only clamp the arteries. Very few patients we clamp the vein. Complex hilar big tumors, only then we clamp the vein, but most of the patient, 90% patient, we do only with the clamping of the arteries, as you can see here. So again, this is individual choice. Most of the surgeons are using only clamping of the arteries. We also do sometimes super selective clamping, but in the selected case. Now when you start the cutting of this tumor, it has to be cold cut, otherwise it can distort the margins of the tumor. And then very important, in this we are doing in-echo resection. A part of the normal parenchyma is taken along with the tumor, and you have to follow the plane. You should not go into the tumor, otherwise you will have positive surgical margins. And because of the robotic vision, you can actually see that there are no macroscopic surgical margins. In this case, it's a posterior hilar tumor, so the PCS was definitely open, and I always prefer to close it using a 3O vacuole suture separately. And I've never encountered till date any case of urinoma or a perinephric collection. I don't put any stent afterwards. Then we start 2-layer renography. The first layer is a 3O V-lock suture. We start from one end, we take internal bites. This will take care of the bleeders. And then we come from the other side, the reinforcing hemolock clip. Then we are going to flip the kidney and unclamp the artery. Now this will save our warm ischemia time, and then we can go back for the second layer. So this step we have used in most of the patient now to save our warm ischemia time. And that's the outer layer of renography. We are using a 2O V-lock suture, again reinforced by hemolock sutures on clips on each side. Now here you have to see, this is a hilar tumor. So in the middle part, we have nothing to close. So we leave this part open. It's a modified kind of renography, and we are closing on the lateral side. So this is how you modify as per the case. And then as we come out on this side, we just put a reinforcing clip right there. Now we don't use a flow seal in all the patients. If it is available, we put it. Otherwise, it doesn't make any difference. If your renography is good, you always decrease the pneumo to 8 millimeter before make sure that everything is all right. So now, after that, you can see that's the specimen. And in this patient, typically the warm ischemia time was 18 minutes. Operating time was 90 minutes. Blood loss was hardly 50 ml. Histopathology was clear cell RCC, negative surgical margins. Now, we always prefer early mobilization of the patient. Brain is typically removed on second post-op day and patient discharged on the evening. We always review the histopathology report, and a CT scan is done at 3 months. So now, as advised by my mentor, Professor M.P. Gupta, we are doing a prospective randomized trial between a robotic and a lab, a 3D lab partial nephrectomy. It is still undergoing. And I just want to show two slides that this is the initial data. We have seen the tumor size and the renal scores are comparable, and the mean operating time is slightly higher in the partial lab group. Similarly, the blood loss is higher in the lab group, and ischemia time is slightly higher in the 3D lab group. However, the positive surgical margins, they are comparable, and complication rates are again comparable in both the groups. Again, I will say it's initial data, and trifecta outcomes are again comparable. So we have a follow-up only 3 months till date, and we have seen that shorter operating time and a lesser blood loss and lesser vomit time in a lab group, but comparable trifecta outcomes. This trial is still going on. So with this, I complete my presentation, and thank you for your patient listening.
Dr. Amles.
Very good presentation, Dr. Anoop. You have, in a very short time, you have collected a good series, and you have been doing 3D lab. So most of us straight away started doing robotic without going through the 3D lab experience. And the only thing I'm sure all of us have had the same experience, that on right side, we always find many more arteries compared to the left side. And I think the obvious reason is that because of the branching that happens behind the IVC in both laparoscopic procedures and in robotic procedures, we don't go as behind the IVC as we go in open surgery. But perhaps if you had gone a little behind the IVC, the lower two arteries, the lower two branches could have actually been taken as one. The upper one was obviously significantly away and separate, and this is a usual problem on the right side. So many times we have to put 4 bulldogs also on the right side, and on the left side the number of bulldogs required is usually less.
Yeah, I think so. You're right. We always try to dissect as close to the IVC, and very rarely also we go retro IVC for dissection of the main renal artery. But as I told in this patient, it showed 2 accessory arteries. So I didn't go behind the IVC because I thought they are 2 accessory arteries. But you're right. If you, in some patient, you go behind IVC, and you might avoid looping all the vessels, you just loop the main trunk. Right, sir?
Yeah, thank you, Dr. Anoop. Thank you very much. Now we can invite Dr. Kishore.
Can I say something?
Kishore, sir, yes, please, sir.
Yeah, no, Anoop, you have mentioned that you are doing a randomized control trial. Though it will be too early for you to make any comment which one is better or not. But I want to ask you one more question. Have you included the surgeon's fatigue factor in your study? Because, you know, that is the one thing which always everybody gives the excuse that I can do 3 cases robotically and only 1 case laparoscopically. So will you, that is my suggestion. That
yeah, Anoop, I think you have to take suggestion of Professor Gupta, because that's very valid, and kindly incorporate in your study. Thank you very much, Dr. Anoop. And now we can proceed for the next speaker, Dr. Kishore, please, because time is not permitting it.
Dr. Anoop cannot take into consideration because he is young. So how can he take the fatigue factor in that?
Sir, wo dekh lega, sir. Okay, thank you very much, sir, for your comment. And now Dr. Kishore.
Can you hear me? Hello?
Yeah, Dr. Kishore, we can hear you. Okay. Dr. Amles, you please take over.
Yeah, so my presentation is not a single video. It's like a multiple clips of depicting the steps of IVC thrombectomy. So just to be on the same page with everybody, what we call it as level 1 is in the renal vein, level 2 is in the IVC, level 3 getting into the intrahepatic IVC, and 3 is divided into A, B, C, and D. There are different classifications. So this is the classification I'm basing on my talk. Okay, so this is the level 3, as I said. So generally, when it comes to the open surgical approach, we see like a large incisions with the constant ooze and collateral bleeding, and we have difficulty in controlling the renal artery up front. But in robotics, probably we can have an easy access to lumbar veins, early approach to the renal artery, reduce venous bleeding for the pneumoperitoneum, and a secure control of IVC and easier access to adrenal fossa. So the steps, one is colon and liver mobilization, just like in nephrectomy. Then comes the lumbar vein ligation, renal artery ligation in right side, cable control, then division of short hepatic veins in level 3 thrombus, and division of the thrombus with the stapler, and you take out the specimen after that. That's a completion of radical nephrectomy, and then cavotomy and closure. So coming to the first video, this video shows how do you tackle the lumbar vein. So this is a right-sided tumor, and your left arm basically lifts the lumbar vein up, and assistant is clipping the lumbar vein, and you can see the left renal vein on the right, on the cranial aspect. And the lumbar veins can be large, small, depending upon the clip size. You can use a Hemlock clip, or you can even use a stapler if it's a very large lumbar vein. So this is how you tackle the renal artery in the interaortocaval region. So in right side, I think it's mandatory to do it because you get early control. You don't run into the collaterals and thrombus. So again, Hemlock clips can be done. And artery is divided in between. So the left side, just like a routine radical nephrectomy, but in the right side, you have to go to the interaortocaval region, lift up the IVC and do the. So this is the utility of fourth arm. So whenever you need, you can even lift the IVC with the fourth arm. It helps a lot. The only things that you have to be careful to avoid any clashing of the instruments. And you have to be always cognizant about the fact that fourth arm is the holding the IVC, it's a vital structure. So once you dissect like the renal artery, take care of the renal artery, and then you dissect the lower pole of the kidney, and then you can staple the renal vein. Actually, this one in fact had a big thrombus, but it doesn't look like there's a thrombus. So it's on the right side. And it is being stapled, and there is a bleeder there which is being clipped after that. So this is on the left side, similar stapling. So the left renal vein, we have almost dissected till the junction of the IVC through the pre-aortic groove, and then it is being stapled. So that's a stapling in the left radical. Then you take out the specimen. So once you dissect, take out the renal vein, then you go for the adrenal vein. So this is the right side adrenal vein. So it has to be meticulously dissected. And all the way up to the base of the liver on the right side. So this is in a level 3 thrombus. What additionally you have to do, this is a thrombus which is extending into the liver. So routine maneuvers may not be adequate for this. And here see, I'm ligating the first short hepatic vein, divided in between the Hemlock clips, because it's quite a large vein. That's why I chose Hemlock clips. So here you can see the IVC is here, and this is another short, small vein which is being ligated. And then you see something called the hepatocaval ligament. So this is a ligament which is connecting the caudate lobe of the liver and the cava. Once you divide this, you will see all the way up to the underside of the diaphragm. So this is small, short hepatic vein again going into the caudate lobe. So you divide it, you will reach all the way posteriorly until up to the diaphragm, actually posteriorly. But anteriorly you have the major hepatic veins. You see, this is the Doppler, the utility of Doppler to see the extent of thrombus. So I found out the thrombus is extending further cranially up. So again, we divided some more short hepatic veins. So by this maneuver, we almost divided all the short hepatic veins, and the liver, right lobe of the liver is almost very well mobilized. And then I just loop the IVC across. This is the additional maneuver in level 3 thrombus. The same case where the thrombus is taken out, quite large thrombus. So once you do the thrombectomy part, you suture it. This is something similar to the transplant cases. You use a 5 or a 6 Gore-Tex. I suture from one corner and then start from the other corner and suture in between, tie in between. So at the end of the final suture, you just let out some blood and take off all the clamps. Then at the end of the, after taking out the clamps, I tie the sutures together. This is you letting out the blood and tightening the sutures and then taking out the clamps. This is on the infrahepatic. This is the right renal vein clamp. And the suprahepatic. The control generally is made by using the tourniquet and also the additional application of the bulldog. And then you tighten the cavotomy stitch. So this is the final scar of the patient. I can take the specimen through a small phalangeal incision with some ports. This is a right side IVC thrombectomy. Then the question is which patient to select or which patient not to select. That is another issue. So this is one case I had to abandon in between because of severe desmoplastic reaction. So because I'm not like very comfortable with the anatomy. So severe desmoplastic reaction, IVC cannot be identified properly. So this case we identified. So when you think about IVC thrombectomy, it can be a little bit intimidating, but actually it's quite safe enough to do that. For example, the only major structure you're opening the IVC, and you can do it in perfect control. If some of the lumbar veins are missed, you can make a small nick in the IVC and suture it back. So currently, I select the thrombus depending upon the level. More than level 3B, I don't take. And if there is the IVC wall invasion, it might be difficult, but you can still give it a try. You can place a patch or a graft. And depending upon the surgeon experience and your comfortable level. And if the patient is poor performance status, better not to venture into it. It has got good advantages like early control of renal artery, especially on the right side. And intraoperative ultrasound is definitely very useful. And it has to be, the caveat is that it has to be, IVC has to be thoroughly isolated and mobilized before application of vascular clamps. And most often when I've converted, I've seen it's non-progression rather than hemorrhage, probably necessitated the need of conversion. So IVC thrombectomy is a very good surgical option to be done robotically, and it achieves good oncological results, at least the early studies. And definitely easier, like earlier patient ambulation, reduced hospital stay, and good cosmetic results. Thank you. And next, probably you have to do the level 3 and level 4 thrombus.
Dr. Mlesh.
Yeah, congratulations, Kishore. Very good videos. Hello.
Yes,
sir. Ask a question to Kishore.
Yeah, Kishore. Regarding, you said that it is easy to control the artery early in robotic. What is the exact reason? Because in open surgery, the first step that we normally do is control of the artery. And why is it that in robotic is it easier compared to open surgery?
Because in the right side, especially because if you're like going onto the right side, either you have to mobilize the kidney in open, like you have to flip the kidney posteriorly and tackle the renal artery posteriorly. So you can encounter a lot of collaterals. And these kidneys may not be very easily accessible and cannot be lifted up as easy as we think because the large size of the tumors. But on the other hand, robotics, once you reflect the colon, you can go to the medial border of IVC and get beneath the left renal vein and take care of the renal artery. So you don't get into the collaterals at all.
No. In open surgery, the first step that you do is control the artery. And for right side, you go into the interaortic groove straight away. you make an incision in the posterior peritoneum just to the right of the inferior mesenteric vein. And there you identify the left renal vein. You reflect the left renal vein a little above. And on the lateral side of the aorta, you'll find the right side artery very easily. Okay. And similarly, if you go to the left side of the aorta, you may have to ligate the lumbar vein. Apart from the lumbar vein, there would not be anything significant on the left side of the aorta. So actually in open surgery, the first step that you actually do is control of the artery. Dr. Anand is trying to say something. I would, yeah, Dr. Anand, please.
Yeah, actually, in for level 3 thrombus, Kishore, you said that you ligate the short hepatic veins. Are you mentioning of caudate veins or small veins which goes clear to the IVC? Because hepatic veins cannot be ligated because they drain the
caudate vein. He's talking about caudate vein.
Talking of
caudate vein.
Short hepatic veins also. Some of the short at the end of the you can common hepatic vein, middle hepatic vein, and the right and left. Major hepatic veins can be left behind, but the rest everything can be ligated.
Right.
When you
I think.
Yeah,
thank
there are a lot
you,
of people who want to make comments. I would say,
I think Dr. Kishore
and Sudhir Rawal, and then Rishi. Rishi also.
Yeah, actually, Dr. Dr. Yes, I have to just intervene. Yesterday, there was instruction from the moderator. We should not exceed the time because this has been the usual complaint from everybody. So I think there's no time permitted. Maybe that you can make a comment for 1 or 2 minutes. Then I may not be doing anything else other than finishing and concluding our session. So I think this is the request from Dr. Pranjal.
Okay, let everybody make a comment on the chat box.
Thank you, sir.
I think yes.
Yeah, thank you very much, sir. And with this, the first session is getting over. Thank you so much. It's very interesting video.
Thank you, Doctor. Thank you.
Thank you, sir. Thank you very much.
Thank you, Dr. Pranjal. Thank you very much, Dr. Pranjal. Thank you very much. Thank you.
Let us go to the second session, and that is mainly again is uro-oncology. In first session, we just mix up with the reconstructive, some of the unusual reconstruction, and especially in a pediatric, which was there. In second session, now we have a uro-oncology done robotically. And may I invite NP Gupta sir and Mallikarjun C sir to take it over and proceed with the show. Thank you, sir.
Sir Gupta sir.
Thank you, Pranjal, for inviting to join for this very good session what I have observed so far. Now we go to the second session, and we have 1, 2, 3, and 4 presentation. And as has been requested, I think so. Please restrict to your timing so that we can finish in time. And we have a first lecture by Dr. Hemang Bakshi on radical prostatectomy. So he would like to show a video. Dr. Hemang Bakshi, please.
Can you hear me now?
Yeah, we are able to hear you. We have not seen your screen yet.
Yeah.
Okay, okay. The screen. Can you see a black screen now?
Yes, of course.
Yes, we are seeing the black.
Okay. So I thank Dr. Pranjal, the USI, and Dr. Rajiv for this opportunity. And I'll be in the next 8 minutes presenting the steps of robotic radical prostatectomy performed in a 67-year-old male with a Gleason 4+3/7 disease. He has an intermediate risk disease with a PSA of 8.6 and a Peyer's 4 lesion on the left. So we have planned a right-sided nerve spare in this patient. And the first step is dropping the bladder down. And normally I prefer the anterior approach over the posterior one, but it's an individual choice. You can go either way. And that is the left vas being the lateral boundary of your anterior dissection. And similarly, on the right side, you drop down the urachus, the median umbilical ligament, and then go down and expose the bones right there. And that is the right vas coming into view. You can either clip it or bipolar it. And then the next step is incision of the endopelvic fascia, which you may do at this point or you may not. I've stopped doing this at this. For the last few cases, I don't disturb the endopelvic fascia till the end. But this is one of the older videos and I used to do that. This is the cutting of the puboprostatic ligament on the left side. And you can see the lateral surface of the prostate here. The advantage of the robot you can appreciate as you push off the fibers of the levator and the external sphincter. The magnification and the wristed instruments help you to do a very precise job at the apex, and that is the key to achieving continence, and that's the superficial dorsal vein being taken care of now. You can bipolar it and divide it close to the prostate. Similar procedure repeated on the right side. The endopelvic fascia is divided, the levator and the sphincter fibers are pushed away, and the puboprostatic ligaments are divided. So now the prostate is defatted, the fat is sent separately for a biopsy, and we come to the bladder neck. So identify the bladder neck and go right at the junction of the bladder neck and the prostate. The angulation of the scissors is important. As you can see, at a right angle, it's very easy to get into the bladder. Then you go on either side, divide the bladder neck, and then that's the posterior division of the bladder neck. Now, the angulation of the scissors will change. It's more horizontal, and then you go at a right angle again till you find the seminal vesicle in the vase, the plane. So you don't want to dig yourself into a hole. So what we do is take the prostatic base pedicles early by a couple of clips so that the area of dissection widens. You are able to dissect out the vase and the SVs better. That's the left vase. You can either bipolar it or clip it. And there is an avascular plane between the two vase deferens, which you follow till you get to the tip of the seminal vesicles. Then lift the seminal vesicles off the Denon VS fascia right there. That's the right vase being divided. Similarly, you can bipolar the small vessels going into the SVs, and then both the SVs are lifted up, and you then go to the posterior dissection, incise the Denon VS fascia in a plane just below the SVs. You don't want to see the prerectal fat. You go till you see the shining and glistening surface of the fascia right there. Then toggle the camera to 30 up on an XI. It's easy to do at your fingertips. And then you go as far as to the apex as you can. And on the right hand side, we have left the neurovascular bundles partly attached to the prostate. The left hand side, because the disease was right there. And you see we use minimal cautery at this point in order to save as much of the bundles as we can. And on the right hand side, we are doing a nerve spare. So first is the retrograde release of the bundle near the apex. You can see the bundle being defined. Then you dissect out the pedicles at the base. And this is the whole neurovascular bundle, which is separated from the apex of the prostate there. So then you clip the pedicles of the prostate near the base, divide it with 2 clips on one side, and then completely freeze off the whole bundle from the apex to the base. So next is the division of the urethra, division of the DVC, which we use using cold scissors, no cautery at all. Increase the pneumo to 15. And you can spot coagulate any arterial bleeder if you have, and follow the contour of the prostate to push the fibers of the sphincters away, and pass a bipolar around. So before dividing the urethra, I prefer to suture the edges of the DVC, which you can do. This is Stratafix 3.0 using continuous sutures, and it helps in a narrow pelvis to use the 30 up lens and then anchor it to the symphysis and then divide the urethra at the apex. We try to preserve as much of the urethral length as possible to achieve better continence, and divide the urethra just distal to the verumontanum, as you can see right there, and make sure that no prostatic tissue is left behind. So that's the prostate out. And then we reconstruct the bladder neck using the fish mouth technique, taking a couple of sutures on either side. You can take a figure of 8 stitch and narrow the bladder neck down to about, and then start with the Rocco stitch. This is a triostatafix. Classical Rocco is approximation of Denonville's fascia to the periurethral tissue, but I prefer taking the seromuscular layer of the bladder to the periurethral tissue because it brings the bladder nicely down. It serves as a good support for the anastomosis coming up, and it also provides good hemostasis at the end. So this makes your anastomosis pretty easy to do. Triostatafix on a single loop, 3 or 4 sutures, and that's the Rocco done. And now the anastomosis begins with a triostatafix double arm needle suture. We begin with the posterior wall, 3 or 4 sutures, mucosa to mucosa approximation. And you can really appreciate the wristed movements and the ease of suturing here as compared to laparoscopy or open. I do all 3 methods, but this by far is the easiest to perform, I would say, at least in my hands. So now then comes the anterior wall, and you leave that suture, the left hand one, begin with on the right hand side. The anastomosis continues on the right hand side, outside in, inside out. Again, take 3 or 4 sutures to approximate the bladder and the urethra. And lastly, put the Foley in because you don't want the Foley to get caught in a suture which you are taking. So I prefer to put the Foley at the end. And there's the final stitch coming up. Now the Foley goes in and the knots. Finally, the lymph node dissection I do in all my cases, even in intermediate or intermediate risk. I prefer not to go lateral to the artery, but take all the lymphatics and the lymph node tissue as a single packet. I'm just showing parts of the node dissection, just some of the anatomical landmarks. On the left, this is on the left-hand side. The distal margin is the circumflex iliac vein, as you can see here, and the obturator nerve coming into view right there. So all lymphatics and lymph node tissue. The key is to remove not just the obturator nodes, but the internal iliac nodes and the nodes near the bifurcation of the iliac, because they are the commonest landing sites in which you would expect a recurrence. And that's on the left-hand side. You clip it because all of it goes into one bag and is taken out. So thank you very much for patiently watching, and I'll stop sharing my screen.
Thank you, Dr. Hemant, for showing a good video on the anterior technique. Actually, you have shown very nicely all the standard steps of the radical prostatectomy. And as you know that every surgeon have tried to make 1 or 2 other modifications in every step. So we will not go into that discussion because then it becomes too lengthy discussion. And you have shown the anterior approach, but it depends upon, again, the training and experience. One can go anterior approach, one can go posterior approach. Somebody does first lymph node, posterior approach, lymph node, then they do the prostate, like that. So I think so we will not go into that discussion. We have discussed radical prostatectomy so many number of times. Mallikarjun, would you like to make any comment?
No, sir. The 2 things which I wanted to say is, I think everybody should adapt to that suturing. You also say most of the time, so the DVC before you divide the urethra, that will be see afterwards. And that's number 1. And I saw you bearing that levator ranae muscle. Is it a routine thing, or it was only in this case which you did it?
We normally don't bear it. This
was completely barren.
So normally we leave of the fascia covering the levator. This was a one-off case, but now we don't even, we pivoprostatic ligaments also at the end, because we know exactly where to go.
That's a
good point.
That's a point. I just want to. So suppose if it's a locally advanced disease, that's what most likely to be necessary. I saw you sparing the nerves at the same time taking out the levator and fascia. That's the reason why I asked it.
Actually, even this dissection of the neurovascular bundle, there is a retrograde approach. Now there is an antegrade approach. So, all surgeons are trying to make one or other modifications, but ultimately, I think so in long run, the best results, what you get in your hand is the best thing you should do. Actually, you should follow one technique. Try to do some modifications if you like. We can move on to the next. Malikarjun, can you introduce the topic?
Yes, sir. We'll call Gagan Gautam, radical cystectomy with extended pelvic lymphadenectomy, semi-live in 10 minutes.
Thank you very much, sir. I'm glad you specified 10 minutes, not a second more.
I'm sorry, 8 minutes, I would say. I'm sorry, 8 minutes.
A very good evening to all my seniors and teachers, and hello to all my friends. What I'll be showing is exactly what Dr. Malikarjun has said. Sharing my screen now. Right, sir. Is the blank screen visible, sir?
Yeah, go ahead.
All right. Can you see the video?
Yes, yes.
So I'll be just touching some key steps in a radical cystectomy. And of course, when you start off with the mobilization of the ureter. This is a male patient with muscle invasive bladder cancer. The ports for an XI are just placed in a straight line about, say about 2 finger breadths above the umbilicus. When we mobilize the ureter, we have to be very careful that we should leave a rim of fat around the ureter because we want the vascularity of the terminal ureter not to get compromised. The second step is creation of the posterior space where you want to go behind the seminal vesicles. You don't have to individually dissect out the seminal vesicles. You go behind the vas and the seminal vesicles, identify the Denon-Vies fascia, cut it, and then find the plane between the prostate and the anterior surface of the rectum. And of course, if this is a sexually active male, you want to leave the Denon-Vies fascia on the rectum and stay close to the prostate at this point. Once you get to the apex, you stop there. The third step is the creation of the lateral space. And this is the space that you create just lateral to the medial umbilical ligament. And you go right down till the endopelvic fascia. You divide the endopelvic fascia to dissect between the levator ani and the lateral surface of the prostate. And one mistake that I used to do initially was that I used to be pretty close to the prostate, and as a result, there used to be some bleeding. But you have to be a little bit away from the prostate here so that you don't get into the periprostatic veins. Well, there are a number of different ways to figure out how to control the lateral pedicle. This is an earlier video about 2 years back. So we used to use the endo-GIA stapler with a white load and then fire 1 or 2 loads to get the pedicle in one shot. But nowadays, for the last 2 years or so, we've been using the vessel sealer on the XI, and that makes life much, much simpler when it comes to handling the lateral pedicle. These are exactly the same steps being repeated on the left side. You would notice that the ureters have not been divided till now. We want to leave them unobstructed till the last moment and divide them only once the entire lateral dissection and the dissection has been performed. So another way to handle the pedicle is actually to use clips. It's a little bit cumbersome. You need to use a lot of clips, but you can sometimes do it if you don't want to use a stapler. And then of course you can take the medial umbilical ligament with the clips and then fire the stapler further if you require. When you go down onto the prostate, if you want to preserve the neurovascular bundle in a sexually active male, prostate pedicle should be taken with clips, and subsequently the dissection should be performed cold without using any vessel sealer, without using any cautery. And here you can see that the neurovascular bundle has been dissected off the left side of the prostate, and even the part of the neurovascular bundle which is actually spreading onto the lateral surface of the prostate is dissected out without any cautery. There will be some bleeding, but it can be managed. The other way to manage the lateral pedicle is to do the vessel sealer. This is an alternative approach to the stapler, and this makes life really simple because you can actually achieve a swift and fast dissection of the lateral pedicles with very minimal bleeding with a vessel sealer. It does add some cost to the entire process, but it's well worth it when it comes to convenience. So this is the ureter being dissected out. Whether to send a frozen section or no is something which is a question of a personal preference nowadays, but the ureter can be clipped and divided at this point when the dissection posteriorly and laterally has already been performed completely. The next step is to create the space of radius and drop the bladder from the anterior wall. This is pretty much similar to how we would do a prostatectomy and is pretty standard. Of course, once you get to the anterior most portion, you can complete any remaining dissection of the neurovascular bundle and make sure that it's not coming in your stitch. It's already been dissected out all around. I usually take a DVC stitch for the dorsal vein complex at this particular point. And you can, it's one important point is to actually take the DVC stitch through the puboprostatic ligament. That way the stitch will not slip when you divide the apex of the prostate. If you just take it behind the puboprostatic ligament, it may slip. The next step is the apical dissection. Of course, at this point, you will have different approaches depending upon whether you're planning to create a neobladder or whether you're planning to create an ileal conduit. If you're planning to create a neobladder, you have to leave a good length of the urethra here. You have to open the urethra. And of course, you have to, then you can take out the catheter, clip it and divide it. If you are doing an ileal conduit, you can be a little bit more merciless on the urethra and actually put the clip right on the urethra after taking out the catheter. And then divide distal to it. So once the bladder has been dissected out completely, we can place it in our indigenous bag and then proceed with the lymph node dissection. We usually do an extended pelvic lymph node dissection, though there is a little bit of controversy about how much extension you should do to an extended pelvic lymph node dissection, with recent trials not showing any survival advantage with an extended lymphadenectomy for cystectomy. This is the common iliac lymph node group, which has been completely removed. You can see the common iliac vein on the right side here, and you can see the common iliac artery, which has been dissected right till the aortic bifurcation. This is the common iliac thing. And now we go to distal to the ureter, which is to dissect out the external iliac artery. The ureter needs to be dissected a bit proximally to give you a little bit more space there. And then the genitofemoral nerve, of course, is the lateral boundary of the dissection here. We don't use a bipolar instrument. The vessel sealer works pretty well even at this step to dissect out the lymph nodes. To actually make sure that the lymph node dissection is diligent and complete, one has to go all around the vessels. So the external iliac artery, external iliac vein have to be dissected out from the lateral pelvic wall, and you should be able to get behind these vessels and identify the obturator nerve from behind these vessels. So that way we make sure that the vessels are completely skeletonized all around, and we have made, we've done a good lymph node dissection overall. This is the lymph node packet from the external iliac artery and the vein, which is being separated after going all around it. This is the circumflex vein. Some vein goes over the artery from the vein, and one has to be a little bit careful about it because sometimes it can result in an inadvertent bleeding. Obturator nerve obviously is identified and preserved. And you can actually remove this entire packet in one go. The internal iliac artery, of course, needs to be identified and skeletonized as well to complete the dissection here. This is the origin of the obliterated umbilical artery. This is the lymph node which has been removed. Now the thing that is left is a section of the triangle of Marseille, and that is a triangle where you find the obturator nerve coming out from the psoas muscle behind the external iliac vessels. And the base of that is actually formed by the sciatic nerve. So you should be able to ideally identify the sciatic nerve there in the triangle of Marseille and make sure that you get this area cleaned out, because sometimes you can have these lymph nodes sitting around behind the common iliac artery there. So this completes the lymph node dissection, and also the same thing obviously has to be repeated on the next side. This is the final picture of the lymph node dissection. And I stop and I will hand over the mic to Dr. Mallikarjun. Completed well in time, sir.
Very nice video, Gagan. I think I appreciate the fantastic video and the nice steps, very nicely divided into multiple steps. The only one thing which I usually get a problem with is with a large prostate. Patients with 150 grams and 300 grams or 120, even 100 grams prostate is one thing where only a posterior dissection getting into that pedicle beyond just a prostatic pedicle or a vesicoprostatic junction becomes a difficult thing. What is the tricks? You have anything onto the upscale?
So I don't really think that that's going to be a major problem, because I mean, we do a radical prostatectomy and we sometimes have to deal with large prostates. But my only point is, sir, that one should be able to go comfortably as far as possible. Sometimes doing a 30 up with a camera will help you go below it in a little bit of a more efficient way. But sometimes it does happen that the last part of the neurovascular bundle or the last part of the attachment of the prostate and the rectum is very, very difficult to dissect antegradely. And in which case you can actually use a retrograde approach, and after dividing the catheter, hold the catheter with a forearm and pull it back and come back. But you have to be very careful there, sir, because the rectum is almost begging to be injured.
Tented there to get begging yes. To get cut.
Yeah. So you should not oblige it, sir.
I know that. Gupta, sir.
Gagan.
Sir.
Hello. Gagan,
sir.
Can you hear me?
Yes, sir. Very clearly.
So it was a nice video with all the steps you have shown very clearly. Only one point I want to highlight. You showed nerve sparing on one side. I think so when you are doing a radical cystectomy, there are definite indications for the nerve sparing, and how do you choose your case, and what all precautions you should take, not only saving the nerve at one place. So that has to be kept in mind actually.
Absolutely, sir. I agree. And firstly, the decision has to be taken whether to do nerve sparing at all or no. That's very simple. Sexually active, nerve spare; not sexually active, no, not nerve sparing. Nerve sparing, like you correctly say, sir, has to be done bilaterally. You can be more aggressive about nerve spare, especially if you're not expecting any prostatic invasion or a T4 disease. And nerve sparing has to begin right from the point that you go behind the seminal vesicles. You have to be very careful around the tips of the seminal vesicles and follow this entirely through to the apex of the prostate. And one has to one can be very good, very liberal about nerve sparing, because one can go laterally on the prostate and spare all the nerves there rather than just sticking to the lateral neurovascular bundles.
And one more point, when you are doing a neobladder after radical cystectomy, previously I have seen in open technique, some surgeons used to leave a cup of prostate there, so they will have a better continence and better hold of the sutures. So what is your comment on that? Should be left or should not be left?
Sir, I am a little bit afraid about the oncological impact of this. So I have not done any prostate sparing neobladders as of now, sir.
Okay, thank you. We move on to the next presentation by Dr. Yuvraj, and he is going to talk about the urinary diversions following radical cystectomy. Dr. Yuvraj, please.
Yuvraj? Yep.
We are seeing your screen, Yuvraj. Go ahead.
We're not seeing him. Yuvraj?
Is Dr. Yuvraj here? No?
The screen is there.
Yeah, can you hear me now?
Yeah, exactly. Loud and clear.
Yeah, okay. Good evening. Thanks, Dr. Rajiv and Dr. Pranjal Modi to give this opportunity. So now you have seen a wonderful video by Dr. Gagan Gautam. Friends, we know that, the urinary diversion, so we used to do it extracorporeally, and majority of the surgeons do extracorporeally in the world. So intracorporeal urinary diversion is an additional advantage of robotic surgery. So I will show you two videos, one of neobladder and one is ideal candidate, how I do it. So there are many methods to do it. So now, so this is the position. So all of you know that. So the position, the Tendelberg position is decreased when we do a neobladder or ileal conduit. The positions of trocars. So the standard, so generally what I do is that I take a 8 millimeter fourth port on the right side, so that we have two arms with the two graspers. One is the prografts and one is the cardiac forceps, what I use. And the 12 millimeter just above the left superior iliac spine for the, this is the assistant port, what we use it for the stapling technique. So this is how we put the ports. So the most important is the grasping ports. So what we use is a cardiac, or you can do double fenestrated interstitial clamp. In brief, the steps are these ones. So this is just to understand how to create a neobladder. So either anastomosis, isolation, detuberization. You will see this. The first step is to take the ureter to the other side. And the most important step is identification of the bowel segment. So identify the ileocecal junction and identify the loops. So the most important is that. So the bladder which I do is modified Karolinska-Studer ileal neobladder. So you can see that 30 centimeter from the ileocecal segment leave behind, and 20 centimeter on the ascending and the right and left limb, and 15 centimeter unopened segment. So this is totally around 55 centimeter, 45 to 50 centimeter interstitial segment we take it. So we can see that. So the most important is that while doing surgery is to have the tags. So this identification is very important. Sometimes you miss it, especially in obese patient. So I use different colors of the stay sutures. And as described by Peter Wiklund, so the first step is to anastomosis. Before anastomosis, for all patients, I take a posterior Rocco stitch, very similar to what we do it in prostate cancer. And with that, so the major tension what we have in our mind, concern is that whether the bowel segment reaches other, this is the first step what we do. And once we do that, so remember that posterior stitch is towards the mesentery, that is the posterior mesenteric line. And then we open the intestine, so it is the size of the urethra, and then do neobladder anastomosis. I use 4-0 VLOC for this procedure. So I do first one is the posterior line, and this is the second one. So this is the female patients. We did the cystectomy followed by the neobladder. So and the anterior layer completes. So the anastomosis is completed. The next step is to divide and isolate the intestinal segment. So you can see that. So we use a wide stapler, that is a vascular stapler, 60 on either side. If you want to extend, so then we usually take NCL and extend it. And the classical, so I just hold the intestinal, open them and put a 60 blue and then followed by a 45 blue. So this is how I do side to side anastomosis. And then, so the most important not to open this very much, so that we can use only one transfer stapler. So once the intestinal anastomosis is done, so then next is to detuberalize the segment. So the right and left segment is detuberalized, so you can make out, and be careful that you have to be in the antimesenteric border. You can see that. And when you go towards the urethral, so you have to be towards the mesentery. So don't take much here, because the segment of intestinal segment between the urethra and anastomosis should not be very thin, otherwise. So this is the posterior layer. So once we take multiple stay sutures, so that we don't miss anything there, because it coils inside. Sometimes we miss it, and we use a 3-0 Statafix. So this is 20 centimeter, an ideal length, most important. Otherwise, it's frustrating. And then this is the double folding. What I did it now. Once we do the double folding, we finish the right side, and then so starting from the midline, we go to the left side. But left side we don't complete completely, so we do it only 50%. So that's double folding and like a Studer neobladder, and then we do ureteric anastomosis. The standard ureteric anastomosis is what we do is a Bricker's anastomosis. You can see that we put a stent also. So through the mesenteric border, we pierce it and then take it into the ureter. So I usually do the anastomosis from outside, not from inside. So for this we use against the Statafix, but it is 4-0. So I don't use monoclonal analysis, only for stay sutures at 6 o'clock and 12 o'clock. You can see that once you finish one side, you can take it to the other side. This suture is double needle, so you can finish one side and then you continue with the other side. So put a knot in between so that it doesn't slip into the so you do first layer, and sometimes I do the second layer also to cover it up. And then for all neobladder, I use suprapubic catheter. Some people don't use it, so we just put a supracath. Through that we put a catheter, and then once we do the suprapubic tube, then we finish the remaining left limb of the anterior suturing. So we have a right limb and a left limb like this, and then we put a saline and see the integrity of the neobladder. And both the ureteric stents are exteriorized, and then the SPC is outside. We put a catheter inside, and then drain and out. So as of now, so we have done 22 neobladder, only one female neobladder. So generally, the complications are acceptable when compared. So there are no major complications. So that's about the neobladder. Then we have a ileal conduit. So ileal conduit is the most common method of urinary diversion in robotic surgeries. Almost in our practice, it is 90%. So these are the steps is very similar to what I showed earlier. So we usually take an umbilical tape and measure it. It's very easy. So flexible. So you can, only thing is don't hold the intestine much. You can hold the mesenteric margin of the intestine. Again, taking the stage sutures very important. 2 stages sutures are taken. And then, so you can see that. So this is the segment. Usually 15 centimeter we take. Sometimes if the patient is obese and we think that it is more is required, we may go to 18 centimeter. And then we take another. This is the proximal stage suture. How do we identify proximal or distal? So one limb will be shorter there. So if the sigmoid is falling on, I just clip it to the left part of the pelvis so that it doesn't fall. So generally before cutting it, I usually give this marking. So the reason is that many times we do eccentric cutting, and then it will be very the vascular supply of the intestine may be hampered because of that. So if you mark it, you know where you're cutting it. Once you pull it and you mark it, then it's very easy. Now it's very easy. So we know that this is the distal cut, this is the proximal cut, and then again vascular stapler from the left side. So this is 60 centimeter. Once you do this, then we do the regular anastomosis, like what I showed you earlier. So very nice anastomosis we do. No need to take any vascular sutures here. So you can you can see that number 1 and number 2 very important. This is the commonest complication, the intestinal complication what we face in these situations. You should be very careful. So once this is done, there is no need to close the window and all those things. This is the ileal conduit. This is the distal one. I just open it because we put the stents through that, and then we mark where we are going to put the ureters. So on the ileal segment, and the rest is very simple. So we have to do the ureteric anastomosis. So I never clamp the ureter before. So now I just to hold it, make a spatulation. I put a clip there, so you can see that. So why very good spatulation you should do it. And the tissue around the ureter is very, should be preserved. And this is the first 6 o'clock stage suture. So that is by PDS. And then put a stent there. So you can see that it is going through the assistant is putting through this thing. So you put all along the ileal conduit. It comes out through the hole, and then we put it into the ureter. And then we fix the stent so that it should not slip back. In the end, we are going to remove that when we make the stoma, and then cut this one, and then the stage suture is taken. You can see that. So this technique is very important. So either you can do it from inside. So because we practice like what we do it in open surgery. Again, as I told you, 3-0 statafix and 2 sutures from outside. You can see that usually I take multiple loops and then tighten it so that you should not miss any wall of the either the intestine or this thing, and then few stitches in this thing, and then take it to the other side and finish it up. So this is how we do it, the ureteric anastomosis. You can see that, and both the ureters are are anastomosed, and then we just clear everything. And the first we inside this one, because the air seal, air will not leak, and then we take out the stent first and then fold it, and we don't pull it. You just deflate the abdomen, automatically it comes out. So as of now, we have done almost 240 cases of cystectomy neobladder, out of which 90% are ileal conduit. Consult times, of course, neobladder takes more time, and it takes around 6 to 7 hours. So this is 3.5 hours to 4 hours it takes in ileal conduit. Otherwise, the outcomes are, the perioperative outcomes are better. So oncological outcomes, that it's up to the cancer issue. Thank you so much. So thank you once again. So if you have any questions, I'll be happy to answer.
Thank you, Yuvraj, for showing excellent videos. They are like teaching videos actually. You have shown all these steps very clearly. I like to ask you, you have compared between neobladder and ileal conduit robotic, but have you compared with the open experience? Because you have done quite a good number of open, and between the two, if you compare with open and robotic, is there any difference in the post-operative outcome and all that, or
Yes,
complication
sir.
rate,
So we used
or
to
you
do
think
open.
and cost also, because in a country like India, we have to always consider the cost. You like to make any comment on that?
Yes, sir. So I think there is a difference. So now when we see the patients in the post-operative period, the robotic versus open, so I feel personally there is a huge difference. So especially, even in the neobladder, the patient will be sitting and, walking around on the second day. Perioperative outcomes are better, sir. But as far as the cost goes, I agree with you. So the cost is quite expensive. say for example, so we can't compare with the government hospitals, but in a private setting, so a open radical cystectomy ileal conduit will cost around say 3 lakhs or 3.5 lakhs. So this will cost around 5 to 5.5 lakhs, around 2 lakhs more than the open surgery. But if the patient is affording, we do it. But in last say 6-7 years, we have done only around 10 cases of open surgery, around 240 cases of this thing, because the patient comes in that category. We cannot compare this to any other institute where the money is an issue. So it's always an issue because of the staplers.
Thank you. Mallikarjun, like to make any
Sir, that's exactly what you said previously also. The more you start doing it, your results will be in that part will be better and better and better. Suppose if after 5 years, if even Yuvraj does an open cystectomy, his result will not be matchable to his robotic cystectomy. It will have a better result than open cystectomy. So I think basically instead of a comparison, what have you been doing in the last 5 to 10 years? You better continue to do that so that the results will be much better than comparison at that point of time. I think possibly you got a fantastic videos and you got a fantastic result. The only thing which I had is you had 2 openings into the ileum when you started anastomosis. Raval does a small flap and does it, and you take a, will that not be a problem? I don't think you would have not had it. Otherwise, you would have modified the technique. Like when you do an ureteroileal anastomosis, you made a hole and then you parallelly you made an incision again. So there is a strip of ileum which is incised on both the sides.
Yeah, so that is the reason. So we have to make the urethral cut as distally as possible.
As distally as to the towards the mesentery. That's right.
So that that segment doesn't. So I did a mistake in this case that I use little cautery to open it up. There is no need to use the cautery at that level.
Thank you, Raja. Very nice.
Thank you, sir. Thank you so much.
We'll go to the next one. I think by Dr. Raghunath. Inguinal lymph node dissection for CA penis.
Thank you, sir. At the outset, I would like to thank USI, Dr. Rajiv and Dr. Pranjal Modi for this opportunity. I would be presenting robotic video endoscopic inguinal lymphadenectomy. As you know, the indications are, commonly in urological practice we do for carcinoma penis. However, it can be also done for carcinoma vulva, say urethra, and surgical oncologists sometimes do for melanoma. So this is the technique. Port placement is standard. Some people have tried even with lateral port placement. Standard in the sense what is described for standard video endoscopic inguinal lymphadenectomy. However, for robotic video endoscopic inguinal lymphadenectomy, we put the ports slightly lower, maybe 2 centimeter. All the ports would come slightly 2 centimeter lower than the standard port placement for standard veil. So creating a subscarfous fascia or space, generally we use finger when we cut the skin, and at the place of optical port, when we insert the finger, invariably it goes into this space. So it is not at all difficult. Some people have used even balloon. I think Gagan uses balloon. So many a times we use finger. And the plane of dissection after port placement, there are 2 ways. Either you can dissect the superficial lymph nodes, or you can go directly to the deeper lymph nodes. Earlier, I used to go with the superficial lymph nodes. Now, I've changed my technique. I go directly into the deeper tissue, and then later on, you drop all the fibrofatty tissue from the scarfous fascia. The advantage being, you don't need to dissect, or you don't need to retract the fibrofatty lymphoid tissue when you are dissecting near the vessels. That is the biggest advantage of going directly to the deeper tissue. So here I would like to present a case, 56 years male, non-diabetic, non-hypertensive, the known case of CA penis, post partial penectomy. He had a left palpable 3 centimeter lymph node. You can make out on CT and PET CT scan. However, PET CT did not show any metastasis. So the tumor board decision was taken to give neoadjuvant chemotherapy. After 3 cycles of chemotherapy, this is again the CT scan or PET CT scan. Very good response was seen. So we planned for robotic video endoscopic inguinal lymphadenectomy. Though there are no recommendation from any standard guidelines to go for robotic veil post chemotherapy, but we have attempted because of our veil experience. We have done more than 100 veils, and we have published in various journals. So this is very important to understand. Before going to the actual video, I would like to spend at least 30 seconds just to understand the anatomy of the femoral triangle. You see here the femoral triangle. This is the left femoral triangle. Above the base is found by the inguinal ligament, and medially by the adductor longus, and laterally by the sartorius muscle. The port placement is very important. The optical port would come 4 centimeter below the apex of the femoral triangle, and the two working ports will come 2 centimeter below and 6 to 7 centimeter laterally, one port, and 6 to 7 centimeter medially, one. And the assistant port will come between the optical port and the lateral robotic port. You can make out the pink one. And this is how we create the space by inserting a finger. Easily you can get into a subscarfous plane. So then after the ports are placed, so this is very important to understand the template, particularly when palpable nodes are there, we have to go for radical inguinal lymphadenectomy. So this is the template for radical inguinal lymphadenectomy. And this is the port placement. You can make out from this that inguinal, the femoral triangle and the template for this. This is the port placement. This is very important because once you're inside with the camera, until you dissect the fascia lata, until you reach the muscles and the vessels, you cannot understand where you are. So when you draw this and ask the assistant to poke a needle through the skin, he will be guiding us where exactly we have to dissect. So you will understand from the video. And the interesting part is we use only two instruments here. One is scissors. The other instrument would be either Maryland or fenestrated bipolar. I prefer to use Maryland because you can do a better and finer dissection around the vessels. So here you can make out, this is the video, you can make out the needle. My assistant is poking a needle at the apex of the femoral triangle and he is guiding me where exactly I have to start my dissection. I'm going to start my dissection at this site. Sorry. So I'm cutting the deep fascia here. That is fascia lata at the apex of the femoral triangle. And whenever required, I'll ask my assistant so that he can pierce the needle. So he has taken the needle out. I will be directly in front of the sartorius muscle and the adductor longus muscle. When these two muscles are joining at that site, I would get the femoral artery and femoral vein. Once I identify, all the landmarks would be identified so that it would be easy for us to dissect further. You can make out the femoral artery. Femoral vein won't be seen at this site. As we go towards the inguinal ligament, we would appreciate the femoral vein. So small tributaries which directly comes from the artery and vein can be clipped or coagulated. Here, this is post chemotherapy. You see a lot of adhesions are there, a lot of fibrosis was there, scarring is seen. So otherwise, getting into this plane and dissection around the vessels is very easy. So we are from the apex of the femoral triangle, we are dissecting towards the inguinal ligament. On the medial side, on your left side, you see the adductor longus muscle. We are dissecting in front of the adductor longus muscle. The medial boundary is medial border of the adductor longus. You can make out the vein. Vein is seen now, the femoral vein. So that is the deep fascia we are cutting. And we go towards the pubic tubercle. Pubic tubercle is the medial limit of the inguinal ligament. So you dissect all around the vessels. Posteriorly, it's not required. Anteriorly and laterally, that is a small vessels. Either you can clip it or you can coagulate. So with two instruments, you can probably complete the surgery. There is a small vessel which is arising directly from the femoral artery that can be clipped. It was a little big, so we are using a clip. Now, if we dissect little further up, we will encounter the saphenofemoral junction, saphenous vein entering the femoral vein. If you wish to preserve the saphenous vein, you can do it, but here we are doing a radical inguinal lymphadenectomy because of a palpable node post chemotherapy. We did not want to preserve the saphenous vein, so we sacrifice the femoral saphenous vein by clipping and dividing it. So you can make out the vein which is perpendicular to the femoral vein. So you can apply Himula clips and divide. So saphenous vein is divided at the saphenofemoral junction. So that is the inguinal ligament. We have reached the inguinal ligament. Inguinal ligament would generally come 2 to 2.5 centimeters above the saphenofemoral junction. And it's very important to remove the cloquet nodes, because here is a palpable node, palpable lymph nodes are present. You have to do even the pelvic lymphadenectomy. So it's always very important to remove that cloquet node. Otherwise, if you start doing pelvic lymphadenectomy, it would be difficult to remove these cloquet nodes from the pelvis. So that is the inguinal ligament. Small tributaries can be divided. You see the artery and vein, femoral artery and femoral vein would be running underneath the inguinal ligament. The white glistening tissue, that is inguinal ligament. So you dissect completely, and now all the fibrofatty lymphoareolar tissue is at the roof of the surgical field. You can make out very well here. See, here the adductor longus is here and sartorius is here. This is the femoral artery, femoral vein with its saphenofemoral junction, and here is the inguinal ligament. And since it was a palpable node, we have dissected even beyond the inguinal ligament, because sometimes retrograde spread can be there. Sometimes we can leave behind some nodes. Just to avoid that one, we have gone beyond the inguinal ligament. So once we do this one, all the fibrofatty lymphoareolar tissue is attached to the roof. We just need to dissect that along the template. So this is the medial dissection. We are cutting the D fascia. So we will encounter saphenous vein here. Unless you are preserving the saphenous vein, you can just clip it and divide. That is the saphenous vein. Sometimes accessory saphenous veins can be there. You would see in a minute. You just clip it and divide the saphenous vein. That is accessory saphenous vein. You can divide. It usually comes from the medial side. So now it's very important to understand the Scarfa's fascia, because Scarfa's fascia is the limit. We have to dissect just underneath the Scarfa's fascia. Generally, getting into subscarfous plane is very easy. Here it would be difficult because of chemotherapy and positive palpable nodes. Otherwise, it would be very easy. So Scarfa's fascia would be seen as a white glistening structure. You cannot miss that structure. You can make out here. That is the Scarfa's fascia, white glistening structure. So whatever underneath that Scarfa's fascia, you have to remove. Sometimes this plane will open up easily. At times you may have to struggle to separate this plane, particularly post chemotherapy. So now we are just dropping all the fibrofatty lymphoareolar tissue, separating from the Scaphoid fascia. So once we do this one, we will come to the end of this procedure. One important thing is, since this is a palpable nodes were there in this particular case, dissection medial to the spermatic cord is very important, because those are the first landing sites. Sometimes even after doing standard veil, we can have a recurrence at that particular site. So it's very important to understand and dissect around that is the spermatic cord. You can make out the spermatic cord. That is the spermatic cord. So here, that is the inguinal ligament. Although fibrofatty tissue has been dropped, this complete clearance of the femoral triangle has been done. That is the whole tissue, which we can eventually going to remove by increasing the incision at the optical port site. So you have to remove all the tissue in front and around the spermatic cord. See, this is the spermatic cord. I was emphasizing to clear all the fibrofatty lymphoareolar tissue around this. Otherwise, the risk of recurrence at this site is very high. So we dissected. See, you can make out this spermatic cord entering the superficial inguinal ring. There was additional some tissue was there around that. As it is a radical surgery, we even decided to remove all the tissue. So out of 17 nodes, 2 nodes were still positive from the left veil. He also underwent opposite veil and left PLND. However, those nodes were negative. So coming to the advantages of video endoscopic inguinal lymphadenectomy, why we should do veil, it definitely reduces the morbidity, particularly when it comes to flap necrosis. It's extremely rare to get flap necrosis, and wound infections are very uncommon. However, lymphocysts are still common, and lymphedema, I would say it is less compared to open surgery. I really don't know the reason for that, where we do the similar dissection, but lymphedema is relatively less. Lymphoria is an issue in our patients, at least minimum 12 to 15 days, they will be carrying with the collection devices like suction devices, drains. So once the drain output comes to less than 10 ml, probably we can remove the drains. Thank you.
Wonderful video, Raghu. Very nice video. I just want to have one question. What in your earlier part of your series, in your learning experience, what were the real problems what you faced? It looks very good for you to see you after so much of an experience to do that job. What was the early problems when you started doing it?
So earlier we used to use with the veil. I used to use the harmonic scalpel. Whenever you use harmonic scalpel, the active blade, if it is turned towards the Scaphoid fascia, we used to get superficial burns. So after realizing that in one patient, we used to turn the active blade away from the Scaphoid fascia so that the thermal damage would be less. And earlier, we never used to dissect all around the spermatic cord. So we had one recurrence. It has to be tackled by open surgery. We make a small incision, made a small incision and removed those nodes. Those nodes were positive. However, the patient did not recur because we detected very early in the post-op period.
Technical complications, I mean to say.
Technical complications are extremely rare with this, sir. If you have little experience, it is very rare to get these complications, except Lymphocyles can occur if you remove the drain early, and lymphocytes can be affected. Other than that,
Gupta sir, Dr. Anand
Can
wants
I
to
ask a
Raghu.
question?
Yes, sir.
Yeah, Anand, can I make my comment? Then we will come to you. Raghu, very good video, no doubt about that. I have two questions to you. You have shown this case where the lymph node was palpable, but there are some other cases where we do a modified Catalona, where we do only superficial dissection. So what do you recommend, robotic for that or not? The second thing is, can the procedure be done bilateral at the same time along with pelvic lymphadenectomy, robotically, all together in one sitting?
So altogether, you can do it. Either you can do superficial. If it comes positive after frozen section, you can go for deeper. You can do bilateral video endoscopic inguinal lymphadenectomy, and you can do bilateral pelvic lymphadenectomy. And with, if you have XI, probably with single docking, you can finish off all the surgeries, all the procedures. Whereas with SI, sometimes it would be difficult.
Okay. Okay, Anand, yeah, please.
Yeah, Raghunath, my question is because the lymph nodes were palpable and you have gone just over the, you exposed the femoral artery and femoral vein. So usually in open surgery, we take the flap of the sartorius and cover the femoral vessels so that there is no bleeding or something. But probably I understand that because when I do this veil procedure, I also don't do it. But most of time we did not have such a big lymph nodes and all that, and we left tissue over the femoral arteries. And probably since there is no flap necrosis or something, so it is not required, or it is omitted in robotic surgery just because of.
Sir, you answered this question, sir. Since the flap necrosis is close to zero, you don't need to transpose the sartorius muscle, as we do in open surgery. Because wound infections are more common with open surgery. If it gets infected, then to protect the vessels, always we transpose the sartorius. It is not required with video endoscopic inguinal lymphadenectomy.
Thank you, Raghu. We go to the next presentation, and by Dr. Sudhir Rawal. He is going to talk on the robotic RPLND. Dr. Sudhir Rawal, please.
Thank you, sir. Can you see my screen?
Yes,
and
we can see your screen. Go ahead.
Okay. Thank you, sir. First, I would like to thank both Rajiv and Dr. Arun, and of course Pranjal, who gave me this opportunity to speak on RPLND, robotic RPLND. Before I go to the video, I'll just make a case for robotic RPLND in testicular tumor. Can it make a comeback? So as you know that traditional indications for primary RPLND were, before robotic RPLND or before chemotherapy actually took over, stage 1 and stage 2A chemo naive, or post-chemo any residual masses. Seminoma if the post-chemo residual masses were more than 3 centimeter. Open technique was used, but then it was one of the most morbid surgery of urology, so much so that we were told that this is next to cystectomy. Cystectomy is the most morbid. After that is the open RPLND. There were various complications of bleeding, chyle leak, prolonged ileus, injury to the vessels, ureter, bowel, and retrograde ejaculations. Now, but the time, because of the morbidity of still need for chemo is 30%. You know, chemotherapy does have a morbidity, and unnecessary you give in 30% of the cases. RPLND in NSGCT stage 1 has shown that it can have better results the patients who are having N0 node or with tumor marker which are normal. Primary chemotherapy does have problem, as I told you. The problem with the primary chemotherapy is also of the teratoma. If you see any teratoma, which can be up to in 20 to 30% of the NSGCT, these patients will not respond to chemotherapy, and they will definitely require RPLND either before chemotherapy or after chemotherapy. So you can offer in a stage 1 when there is a marker normal, or is N1 when the marker normal, you can offer this treatment, because the morbidity has come down like anything because of the minimally invasive nature of the surgery. So I'll just go for the video. I hope it will run. If it doesn't, then I'll go to my primary. I don't know how long is this video. rather I'll go for another video because I have 3-4 videos which are very large. So I'll go for a 9 minutes video. So I'll stop sharing this and go for the video which I feel I'll finish in time. So just share it again. Yeah, that's the one. So we have done maximum number of RPLND all over the world. You can see that this was the CT scan of this patient after chemotherapy, and we used SI for this. SI for this. Any robot you can use, SI or XI. The docking is a bit different. This is, I'm coming from below, from the head end. Patient is in supine. Assistant that he is assisting from in between the legs. He's doing the assistance. The thing which I'd like to say to the junior crowd is never ever write off the patients for open surgery. Never ever offer the open surgery unless you do the dock your robot, because everything depends on the desmoplastic reaction. This patient's on CT scan has a big lymph node, and we had a lot of discussion that we should offer RPLND or not. Then once we started doing RPLND, then we realized there is hardly any desmoplastic reaction, and we could do. There is another video on my YouTube channel, Surgical Oncology, Uro-Oncology Surgical Technique, where full video without editing is there. Not this one. That is probably better video than this. You can see it there. Also, lymph nodes were big, but we could remove them without any problem. So you, after cutting the mesenteric root of mesentery, you go to the lymph node straight away and take the vessels. This is the lumbar vein, which is being clipped and cut. No, this is, sorry, lumbar artery. Because this, I'm in para-aortic reason. Because this was left side tumor, so mainly the disease is on the para-aortic side. And you can see the node is going behind the aorta also. You need to take all the lymphatics with the clips, otherwise you may end up in chylous ascites. That's the biggest big problem which I have faced, and now we don't have this. These are the psoas muscle, posterior abdominal wall. You can see here, because this is a big node, so the things, whole anatomy will be cleared in the later part of the dissection. You can see another lumbar artery. There's the aorta. This is pulsation is there. The node is going behind the aorta. There's a big lymphatic, so it is better you take the lymphatic so that you avoid chyle leak. The main thing which you need here is patience. Never ever hurry, because you are working on a big vessels. If you injure them, then there is a problem. You can still come out, because the robot is very handy in sorting the bleeding problem, even from the aorta or IVC. You can see another node there, but I'm removing first para-aortic, and then we'll go on that side, and finally the intra-aortocaval area. So one packet is out, para-aortic. Then we go for the rest of the nodes. These are pre-aortic and pre-caval nodes. You can see that. Again, it's better to take these suspected vessels or lymphatics just to avoid any difficulty if they bleed or if they leak. That's again aorta and another lumbar artery. You can see remaining interaortocaval region tissue. One has to clear tissue all around the vessels and the below the inferior mesenteric artery also. This is the inferior mesenteric artery. If there is not much desmoplastic reaction, you can easily do this dissection. Here you can see the inferior mesenteric and rest of the tissue is coming out. Now we will go for interaortocaval area. You can see the anterior spinous ligament. Some more tissue is coming out from the interaortocaval area only. We will see the right renal artery also. Seeing renal arteries is not a problem from this side when you are coming from below. So much so that sometime in the left side of tumor thrombus, we have taken left artery from this approach only. So it comes right onto in your field. I think we probably had 39 lymph node in him. You can see that lumbar artery is clipped and aorta can be lifted up in the air. So this is the type of dissection you can achieve with robotic. Thank you.
Wonderful, Sudhir. Gupta sir, there were two questions actually, in fact, which we need to be answered after your comments, sir.
Sure, I think so. We'll take the question first. Dr. Philip Raj has asked one question. How long you should wait after chemotherapy before RPLND?
Anytime after 3 weeks, you can offer surgery, sir. After completing the chemotherapy.
About the lymphuria, which is more after the robotic surgery, less with open surgery?
No, sir. It depends what technique you use. You learn also in the beginning of our when we offered this surgery. Now we have done almost more than 26 cases, but in the beginning we were not clipping the lymphatic vessels at the level of left renal vein. there's a place where, you know, cistern chyli and other big lymphatics are there. If you put clip there, you will not have lymphoria. If you don't, then you will have troublesome lymphoria, so that the patient can develop chylous ascites.
Now, I'd like to make one comment about your initial presentation of chemotherapy versus RPLND. I think so, until unless you are doing a nerve-sparing RPLND in early cases, then only it is beneficial. Otherwise, this retrograde ejaculation and infertility, these are the major issues if a patient is unmarried and, you know, something like that.
Yes, sir. In early cases, it's definitely doable. The lymph node like him, we did not saved the nerves, but one can do.
In this case, it is not possible post chemotherapy.
Yeah, but in early cases, we have yes, sir. But in early small nodes, we have the patients who are not having retrograde ejaculation at all.
Now,
I'll take Dr. Anand's question. Sir, Sudhir, I saw somebody.
I'll take one question more, please. Just wait. Santosh Wagankar has asked, is in case of any aortic injury or something like that, you know, that what we should do?
The usual principle has to be followed. You have to have rescue stitch, but though I never had rescue stitch, I did injure aorta in one case, and I showed that video many times in the conferences. You have to keep your nerves with you. Don't just get panicky. Put a instrument that the bleeding stops. Take the rescue stitch and change the needle holder, and you can easily suture. The IVC is not a problem. It's the aortic injury or, you know, arterial injury is a problem. So you have to have your nerves. Don't panicky. If you panicky, patient dies. This is always there. So it's not a difficult thing. But if you have any problem, you just catch so that the bleeding stops and you can open patient anytime.
Yeah, Anand Kumar. Yeah, please go ahead. Unmute yourself.
Unmute, sir.
Unmute first.
Unmute, Anand sir. Anand sir, unmute. Unmute yourself, sir.
Can't hear you, sir.
Okay. Rawal, my question is, when you are going from below upward, then how did you handle the bowel? Did you tag the bowel to anterior abdominal wall or?
Sir, there are two ways. One is you make a cut at the root of mesentery, and this mesentery can be tagged to the anterior abdominal wall easily. But we never required this. We use another arm, like a progress arm, to lift up the that peritoneal fold, and the whole of the vessel, whole of the intestine goes back. But then we make the patients in a anti-Trendelenburg, the head down position, and the right shoulder is down, so that the bowel automatically clears from the field of operation.
Anyone otherwise?
Sudhir, there was one question which was asked for Raghunath. If he's there, if he's not there, you can answer. Is it possible to do a pelvic dissection through a inguinal route only, wheel technique only? Is it possible to do a complete pelvic dissection?
I have no idea. I know that from abdominal route you can do the inguinal dissection. You can do the inguinal.
Some people have cut open the muscles and inguinal ligament. They have done it, but reports are very limited to less than 10 numbers. Conventionally, it is not done.
But from above down, it is possible.
It is possible.
It is going to be the same.
Anyway,
okay.
I think so because of the time.
Ligament do that.
With the time constraint, we have to stop. And I like to thank all the presenters for their wonderful presentation videos. And Dr. Mallikarjun, thank you very much.
Thank you, sir.
And for joining. Thank
you, everyone. Sir.
Thank you, organizers, for involving us.
Thank you, sir.
We can go to the next session, please.
Yes, sir. Thank you very much, Mallikarjun sir, N.B. Gupta sir, and all the presenters. Next session is on transplant, and may I request Dr. Anand Kumar and Dr. Ravindra Sabni sir to take it over and go ahead with the show.
Okay. Dr. Arvind Ganpule is going to present the robot-assisted laparoscopic donor nephrectomy. Arvind, please go ahead.
Yes, sir. Thank you very much, sir. I would like to thank Pranjal sir and Rajiv sir for this opportunity. In the next 8 minutes, I will be talking on the technical aspects of right and left lie-related robotic donor nephrectomy. And then obviously a question is going to come that is it really worth it when we can do the same job very well laparoscopically? So I will try to answer that question using some literature support. So to put through my point, I decided to take these 2 index cases. So this was, as you can see on the left side, there are multiple arteries. On the left side, you can see the main renal artery is having a prehalar branch. So obviously we decided to go on the right hand side, but on the right hand side, we had gotten very short stubby vein. So here I'd like to just make out my point by showing this video as to how a robotic donor was useful in this case. We go into the port placements. As you go through the, as you keep on seeing the video, I'd like to tell you that we used 3 robotic ports. In addition, we required 1 port for liver retraction and 2 for assistance. So the final port configuration was somewhat like this, wherein we used 1 fenestrated bipolar Caesar, and obviously as well as a Maryland. The steps of the donor nephrectomy very closely mimic that of an laparoscopic donor nephrectomy, which starts with the bowel reflection. All the transplant surgeons will agree with me that a recipient surgeon would be very happy with a donor surgeon if he gives 3 things on the backbench. Number 1, a long, well vascularized ureter and very good vessels, particularly in terms of long length of the vessels and good quality of the vessels. So if you want to say that robotic donor is beneficial, then we have to make sure that that it fulfills all these criteria. So the first step would be lifting up the ureterogonadal packet, and the age-old adage that we have been taught in medical college is that always the water flows below the bridge. So don't try to see for the ureter, but try to see for the gonadal, particularly on the left-hand side, and lift the whole thing in toto, so over the psoas muscle, so that you have got a very good vascularized ureter till the point you reach up to the hilum. So you see here already you have started seeing the renal vein, and some part of the duodenum is still there. So we go to the next step wherein we have to identify where is the renal artery. Before that, it's always a good idea to go to the upper pole and then come back to the vessels. As you can see here, you can see very well the early bifurcation of the vessel, and this maneuver helps significantly to the robotic surgeon, that you put in a sling. This helps you in going behind the IVC. So during the retrieval step, you'll agree with me that particularly the retrieval of the artery on the right hand side is a little bit better when you do it robotically. The next step comes that we want to give a good vascularized long ureter to the recipient surgeon. So as you can see here, the gonadal is taken care of, and once the gonadal is doubly clipped, the next step would be that we have to go down to the ureter, ideally up to the ilia crossing. And you can see that the graft is very well vascularized, as evidenced by good jet of urine. The standard protocol of giving Lasix and good hydration is followed. And as you can see that the sling helps us in going behind the IVC. As more number of hands are there when we are doing an robotic approach, because all the clips suction is being applied by the assistant. And the job for the robotic console surgeon is just to give traction so that good length of the artery, particularly on the right side behind the IVC, can be secured, particularly on the right hand side. In this case, we decided to go for an stapler. We used an white stapler so that we take as far as possible and the cuff of the IVC. This can be possible with certain staplers which have got a U configuration, and wherein we can get a cuff of the IVC without losing the length of the renal vein. Following this, the fourth arm is undocked. Rest of the arms remain there. A pre-placed incision is already there in place, and we remove the graft through that pre-placed incision. So you can see here, once the graft is completely freed, we are ready to put in our hand and retrieve the graft. I quickly go to the left-hand side. You see, again, we have got double vessels. So let's see whether a robotic platform will help us in such a situation. The port configurations, again, closely mimic that of an laparoscopic donor. I'll not go into those details. Once the ports are there inside, the 10 steps that we all know about the laparoscopic left side donor nephrectomy are followed. As you just noticed that before placing the ports, it's always a good idea to place and pre-placed incision. In this particular case, we decided to have a fan and steel incision just because the fact that it was a female donor. Again, the first step remains that reflect the bowel extensively to make sure particularly that the spleen drops down. The next step would be identifying the ureterogonadal packet. As you can see that we are almost mimicking that we are doing what we are doing in a laparoscopic donor setup. You can see a good thick periureteral tissue along with the gonadal vein. Once the ureterogonadal packet is lifted up, our next step would be to identify the renal vein, because we know that nothing important is anterior to the renal vein. Identify the adrenal vein, secure the adrenal vein. It may be a good idea to dissect the upper pole first before we take the lumbar vein, as you can see here. Being a dual vessel, in this case, we decided to go to the lumbars first before going to the upper pole, because we ran the risk of entering or injuring the upper polar artery in the event. So as you see, the lumbars have been taken care of, and in the initial CT angiography, you saw that both the vessels, this is the first vessel and the other vessel was lying just behind it. What I want to emphasize here is that the fourth arm that we are using in a robot helped us in retracting the upper pole very well. I'm not saying that this would be the case for advocating a robotic approach, but that was the advantage that we saw, particularly when we were doing a robotic donor nephrectomy. Once everything is ready, we clip the ureter. First clip the gonadal, followed by clipping the ureter. And then we use the fourth arm to make sure that good traction is given on the vessels. Initially, one clip each on the artery before we take the renal vein. Once two clips are on the renal vein, the artery is secured. Again, two clips on the patient side of the artery, and then the graft is ready for retrieval. Again, the fourth arm here would be a little bit benefit, because that will help in giving traction to the kidney and holding the kidney till the hand comes inside and the graft is retrieved. Now, I'm sure that for an uninitiated person, these would be the observations after seeing these two videos, is that an robotic donor nephrectomy will require an additional trained bedside assistant. It requires more number of ports as compared to the laparoscopic donor nephrectomy. And you'll agree with me that the retrieval was more cumbersome step, as it took a little bit longer than anybody of us would be doing it for a laparoscopic donor approach. So what does the literature note on this aspect? So we had conducted a randomized control trial of 50 laparoscopic donor nephrectomies versus 50 robotic donor nephrectomies, and I'll just go through the conclusions. What we know is that laparoscopic approach is the standard of care, and what we do not know is how does it fare vis-a-vis an robotic approach. So these were the four groups actually what we studied. It was an right robotic donor, right laparoscopic donor, left robotic donor, and left laparoscopic donor. And let's see how they fare with each other. As you can see that the demographic data, it's a randomized control trial. They almost match with each other. But what differs is I'll run through this important data. As you can see that the total operating time, in particular, we are considering the right side, is almost comparable. However, significantly, the retrieval time was more. Similarly, the retrieval time, the warm ischemia time was more in a right robotic donor. We also went through the pain scores in the patient, and significantly we saw that regardless of the site, the pain scores were significantly less in a robotic approach. Probably it relates to the sweet spot or the remote center of the robot. Going a little bit further, we asked the surgeon as to what is the level of difficulties they faced when they compared laparoscopic donor versus robotic donor. And as you can see here, two steps, the hilar dissection and the upper polar dissection, were significantly, I would say, a little bit easier in a right side robotic donor. But significantly, all the surgeons said that the retrieval was significantly difficult in the robotic part. So just to conclude, our comparative study suggests that the robotic approach may provide some technical advantage compared to the laparoscopic approach on the right side, but not on the left side. OR time was not significantly different in the robotic donor versus the laparoscopic donor. However, the warm ischemia time was significantly more in the robotic part. And we do admit that the increased warm ischemia time and the retrieval time in the robotic donor may be related to the need to undock the fourth arm during the retrieval. This is also a cause for increased patient-side VAS score, as you saw in the table. The robotic donor increased the cost of surgery for robotic donor, and it remains to be determined in long-term studies whether this is really a benefit as compared to what benefits we saw in the tables that we just saw in the last two slides. So the bottom line is that robotic donor nephrectomy is a safe procedure and is associated with better post-operative pain scores, analgesic requirements, as well as lesser hospital stay compared to the laparoscopic counterpart. robotic approach in the donor nephrectomy is associated with more technical ease to the console surgeon, particularly on the right side, and particularly if you want to have a good length of the vessel when it branches behind the IVC. Left robotic donor is associated with longer warm ischemia time than the laparoscopic counterpart. However, this does not translate into poor graft outcomes. I rest my case. Thank you very much.
Okay, thank you, Ganpule. There are two questions I would ask before Dr. Anand Kumar goes in. That you have nicely demonstrated that you can dissect out the renal artery which is going behind the IVC on the right side with the robotic. The two questions are that if the branching of the artery is significantly behind the IVC, do you think that flipping of the kidney is far better with the robotic than the laparoscopy if you have to go really behind the artery? That is one. And second question is that if the donor is obese, I mean the upper limit for obese donor we take is at 35 BMI. Do you think that is the one factor which will decide whether to go for robot or to continue with laparoscopy?
Thank you very much, sir, for the questions. Yes, flipping the kidney was tried in 3 or 4 cases in our cohort of 50 patients. And subjectively, we feel that flipping of the kidney was a little bit easier as compared to the laparoscopic counterpart. This is absolutely a subjective opinion. But I do feel that it helps in an robotic approach, particularly on the right side, the flipping part. The second question, as related to the obesity, it helps in doing an robotic donor nephrectomy, particularly in an obese patient, because as you can see, more number of instruments are inside and more number of hands are there to help you. Particularly when the kidney is flipping, you have got a lot of fat, you want good retraction, then probably an obese patient would be one of the indications wherein we would be employing the robotic approach.
Yeah, Arvind. Yeah, yes, my question is, okay, so you have done the comparison, you have done both the procedures. So what is now your indication to do robotic donor nephrectomy, and what is your indication to do laparoscopic donor nephrectomy, because you do both? And then I'll ask the next question.
Our preference is to do an laparoscopic donor nephrectomy because our own study has proved that actually the robotic donor nephrectomy, except whenever there is a demand from the patient or there is an early hilar branching behind the IVC, these are the only 2 indications wherein we might go for an robotic donor. Otherwise, our choice would be an laparoscopic donor nephrectomy.
Yeah, because I have not done any robotic donor nephrectomy. We do robotic transplant, but all the donor nephrectomy is laparoscopic. We have done in all kinds of donor, obese, all kinds of donor, but never find any difficulty in doing it. And even flipping the kidney is quite difficult. Just you have to change the instruments. The instrument which is coming from the lateral side, if you use it, you can flip it down. But if you do the right side retroperitoneal donor nephrectomy, you don't have to do any of the things. Then it becomes very easy procedure.
I agree with you, sir. Actually, to answer means corollary to Sabni sir's question, if you want to go behind the IVC, actually a retroperitoneal approach would be a better approach for getting a good stump of the IVC rather than flipping the kidney through a transperitoneal approach.
I think we can cut down the questions here and we go to the next talk by Dr. Prasoon Ghosh, and he will be talking about the robotic kidney transplantation. Dr. Prasoon, are you ready with your...
good evening, everyone. Yes. Good evening, everyone, and thanks for the opportunity. I'll just share my screen.
Okay. Dr. Prasoon is a very senior robotic surgeon working in Vedanta, Gurgaon. And he has done lots of robotic transplantation, and he's going to share his experience here today with the robotic transplantation.
Can you see my videos? Can you see my slides?
Yes, please go ahead.
Okay, good evening, everyone, and greetings from the Medanta Kidney and Urology Institute. And thank to USI and ISU, Dr. Pranjal, our technique of robotic renal transplantation with regional hypothermia. And now, whenever you develop and establish a new procedures, you have to conform to some guidelines which should be able to objectively evaluate and answer this procedure against well-accepted standard parameters concerning about safety, efficacy, reproducibility of the procedure, etc. across the board. We designed our study on the idea of Oxford University, United Kingdom, exploration, assessment, and a long-term follow-up. And our procedure since 2012 has run through various phases of this to reach to the current state. We have published our studies starting from phase 0, phase 1 to about phase 2B, and I'm not going to go into details of those studies. But as we went into the consolidation phase of the phase 2B studies, as the procedure was pretty easy and picked up by most of the transplant centers, not only in India, across various good transplant centers in various cities, it was also picked up across the world by reputed transplant centers and translated into action. So cutting the chase, I will go straight to the video. Can you see my videos, sir?
Yes.
And the audio as well?
Audio is not clear.
Is it clear now, sir?
No, audio we can't see, but video is clear.
Hang on, sir.
In this video, we describe our novel technique of robotic kidney transplantation with regional hypothermia. With the patient in supine position, a 4 to 5 centimeter periumbilical incision is made and extended down to the fascia. After the peritoneum is opened, the gel point access port is placed through the incision. Then, a gel seal cap prepared previously with a 12 millimeter camera port and a 10 millimeter assistant port is fastened onto the gel point access port. Pneumoperitoneum is established and the patient is moved to a 15 to 20 degrees Trendelenburg position. The post placement is similar to a typical robotic radical prostatectomy port placement with the fourth arm on the patient's left side. The surgery starts with the identification of the external iliac vessels, which are then carefully skeletonized, exposing the external iliac artery first, followed by the external iliac vein. Small branches and the lymphatics are controlled. The peritoneum distal to the cecum is divided transversely, and the proximal and distal flaps are raised. These flaps will be used later for retroperitoneal fixation of the graft after the vascular anastomoses have been done. The bladder is then taken down and the extraperitoneal space is developed. The bladder is then distented with saline through the urethral catheter for creation of a 1.5 to 2 centimeter orifice for a subsequent ureteroneocystostomy. After harvesting the graft kidney laparoscopically, it is defatted on the table. Simultaneously, modified 2Me syringes are prepared with ice slush for rapid delivery of the ice slush to the pelvic cavity. Then the graft kidney is wrapped in a gauze jacket with the ice slush. An opening is fashioned to allow access to the hilar structures. The jacket serves a dual purpose of maintaining ice slush around the graft as well as allowing atraumatic handling. The robotic camera arm is then de-docked and the gel scal cap is removed, which allow for easy and resistance-free introduction of the graft kidney into the pelvic cavity. After stabilizing the graft kidney with or without the assistance of the fourth robotic arm, the external iliac vein is clamped using robotic bulldog clamps. A venotomy is made using cold monopolar scissors. The graft renal vein is then anastomosed in a end-to-side continuous fashion to the external iliac vein using a Grotex CV6 suture, beginning with the posterior wall. This PTFE non-absorbable monofilament suture slides through the tissues easily and is strong enough for use with robotic instruments. The anastomosis is flushed with heparinized saline and is then completed. The graft renal vein is then occluded using a bulldog clamp. Both proximal and distal clamps are then removed from the external iliac vein. Next, in a similar fashion, the external iliac artery is clamped. For arteriotomy, first a small incision is made in the arterial wall using either the monopolar scissors or the robotic scalpel. With the help of a 3.6 mm aortic punch introduced through the gel point, a circular arteriotomy is made. The renal artery is anastomosed in an end-to-side continuous fashion to the external iliac artery. Black diamond forceps in the non-dominant hand helps in atraumatic handling of vascular tissue and is useful to spread the vascular margin for precise needle placement. The anastomosis is flushed and the integrity of the anastomosis is checked. The graft renal artery is temporarily occluded and the clamps are taken off the external iliac artery. The vessels are then unclamped, the gauze jacket is carefully cut off and removed. The graft kidney is visually inspected for color, turgor and on-table diuresis. The graft kidney is retroperitonealized using the flaps prepared previously. Also, the pneumoperitoneum is dropped to 8 mm of mercury. After this, an IV bolus of 100 mg of furosemide is given. After fixation of the graft, its color and turgor is reassessed and the vascular anastomoses are inspected. We then proceed with ureteroneocystostomy utilizing the modified Lisch-Greger technique. The ureter is spatulated and is anastomosed with the opening in bladder mucosa in a continuous fashion using 4-0 PDS or Vicryl suture. A double J stent is placed after completion of the posterior layer and uretrovesicostomy is completed. The detrusor layer is closed in a continuous fashion using a barbed suture such as a V-lock 3-0. The abdomen is closed in conventional manner after placing. At finish, an on-table Doppler is performed to check the graft perfusion before shifting the patient to transplant recovery.
Back to the slides. So this was a, can you hear me now? Am I audible, sir?
Yes, we can hear you.
Yes.
But your slides are not seen.
I think he has finished.
Okay.
So, Dr. Prasoon, what do you think is the role of robotic transplantations today in India? You think this should become a very standard of care, or you think it is only in the selected cases where there are classic selected indications for doing robotic transplant?
Probably. As of now, it will be difficult to say whether it is a standard of care or not. But as we go along in time, I'm sure it will become the standard of care over a period of time. But there are very selected indications that you
So
need
what
to.
are those? What are those?
Obese patients. Even, I mean, why would we not offer it to a normal BMI patients as well? So obese patients is one, especially difficult anatomy is second. We earlier used to have very selected criteria for inclusion, but now we have extended. Most of the transplant centers in India are doing second transplants, immunologically challenging transplants, and other various where we have included more of the patients, pediatric transplants, ABO incompatible transplants. So that is the future which this transplant will be coming to. Open surgery will retain its own place, but gradually as time passes, even like many preemptive transplants would prefer a smaller incision, lesser morbidity, lesser pain score for that matter. Also, more preemptive transplants can be motivated to get off the dialysis list to cut out the costs. Less morbidity resulting in lesser hospital stay will again cut the hospital cost. So overall and over a period of time, it may become almost equitable to an open transplant. So what we have done at our institute is, since we are already crossed phase 2B, we have incorporated a randomized controlled trial called as the Proctor trial, where we are comparing the open to the robotic in the randomized fashion. Presently, the limitation is that it's a single center, but multiple surgeons are doing it. And gradually we have about...
Prasun, one last question before I hand over to Dr. Anand Kumar is that, have you done all the cases with the gel point, or you have done some cases with the financial incision? Because financial incision is far better than the incision which you have shown to put the kidney and put a gel point. So what is your experience about that?
So we have not done, personally, I have not done anything with the financial incision. We're still using the gel port. The only comfort that it gives me is that anybody and from my team, the bedside surgeon, can access the peritoneal cavity immediately by just removing this, undocking the robot and removing the gel cap. That is the only comfort we get, but definitely it adds to the cost. And most of the centers are doing it across the financial incision. So that is almost as good as the gel point, except for the cost.
Okay, yeah. Dr. Anand, you want to ask anything?
Just to answer your last question, actually, we have used gel point only in a very obese patients, because there in phalansteal incision area is also, there is a lot of fat hanging there. So there umbilical gel port becomes good, and that is the only indication we have used it for the rest all goes the incision.
Your voice is breaking up, sir.
Is phalansteal incision when you take
mobile भी साथ चल रहा है.
Point.
We can't hear you.
I'll just close my video. Yeah. No, mobile is closed. Okay. Now can you hear me?
Yes.
Yeah, now you're loud and clear. Loud and clear. Go ahead, sir.
Yeah. Now that when you use the phalansteal incision, there is it takes more, because you put then you close the incision and then you start.
Your audio is not clear,
I think there is a problem with some audio internet connection. But I think the point what Dr. Anand Kumar was explaining was well taken. That there are certain specific benefits of gel point, but most of the things can be done by the financial incision. So thank you very much. It was an excellent video, Prasun, and it demonstrated all the points very clearly. So now we next go to Dr. Pranjal Modi, who actually has pioneered the kidney transplantation, robotic kidney transplantation in India. He has probably the largest number, not only in India, but across the world. And he's going to show a very complex case of a robotic dual kidney transplantation with the monolateral iliac vessels. So over to you, Pranjal. Show us your talk.
Thank you, sir. I think I'm not going to show any video, but I'll show you only the photographs. because my intention, already the video has been shown, so there is just not fun of showing the same kind of anastomosis again. So there are very limited indication to do the dual kidney transplant, and commonest is when you get expanded criteria donor when the KDPI is greater than 85, or difficult to manage the recipient on dialysis, like some of the diabetic patient when you lose the vascular access and then they get thrombosis, and then they accept that even the marginal donors are available like greater than 60, 65 years of age. The donor is diabetic or hypertensive, and then there is a Ramsey score criteria, etc. There are so many ways to see this expanded criteria donor. And then patient's acceptance of such kidney when they are on a waiting list, you always ask for the patient whether you will accept such type of kidney or not. So we have a SI robot, and then this is the docking is very standard, like the modified lithotomy position. Both legs are flags. This is, and the robot is docked between the two legs. And these are the ports, the camera port, the fourth arm is on the left side, and then these are the working ports, and only single assistant port which we put nowadays. And the next is like, if you see the dissection. The dissection of the common iliac artery is carried out. You can see the ureter and ovarian vein which are crossing the bifurcation of the iliac artery. This is the internal iliac artery, this is the external iliac artery, external iliac vein. And the peritoneum has been divided at the lower down, and cecum has been pushed upward, so that the patient is in a 30-degree Trendelenburg, almost 30 degrees, so that all the bowel goes up. You can put one kidney over here and another kidney over there. And it's very important, the kidney has been dropped through the pharyngeal incision. The first kidney is dropped inside. You can see the internal iliac vein often on the, common iliac vein, which often comes from the right side. But in this case, somehow we found that it is easy to bring it from the left side of the common iliac artery. So then it was brought up after dissecting. Few tributaries were bipolar, which was going right into the psoas muscle. And then it was the Scanlon bulldog have been used and occluded. So here is the anastomosis completed. Then after the completion of the venous anastomosis, we put a bulldog clamp on the first vein, this left renal vein, which was from deceased donor. And then both the bulldogs are removed. First proximal bulldog applied on the common iliac artery, and then the distal bulldog applied on the common iliac artery. So after that, there is a big, we put a pot scissors, and there is a usual big chunk, depends on the Carl's patch which we are going to use. And so there is a big arteriotomy, no way it can get occluded at any point of time. Then you have to worry only about the bleeding, never the obstruction. Take the very close by stitches, and then thick bite is to be taken. Don't take edges, otherwise it will cut through and go away. So this is very important. Once the anastomosis is finished, you can see that, and then the clamps are open up, and then the kidney is very well perfused. The kidney which was here is now flipped to the psoas muscle, and you can see here with the cecum, and there's a cut edge of the peritoneum, which is just, I'm trying to put the kidney back behind the cecum. Now you can see the external iliac vein, external iliac artery. This is a female recipient, and yes. Now we have finished the venous anastomosis. This is the extension of the right renal vein from the, and then extension of the vein done by elongate through the, using the inferior vena cava. So it's a very broad anastomosis, and less likely that you don't have to cut down all these things here, and you can do a very long anastomosis, and then long enough so that the vein and the artery is almost of a similar length. This is the external iliac artery now. So upper kidney is perfused by this time, and here now we are applying distal to it. The distal venous anastomosis is over. Here we didn't use the Carrel's patch because it was calcified artery and the renal artery ostium, so it was removed, and then the conventional right renal anastomosis has been carried out. Once the graft is perfused, it is placed over the first kidney. You can see this is the flipped first kidney, and over that the flipped second kidney has been placed, and then this is the peritoneal flap which Dr. Prasoon has shown. This is the renal vein of the kidney 1, and then the peritoneum which is cut edge over here. This is been clipped. Several clips have been applied, and completely this has been retroperitonealized. And 2 ureters are implanted separately, and so that's how the dual graft functions. And this is the post-operative outcome. as we put a financial incision rather than in the support, the camera port incision. Rest of the, I think, so the two grafts in iliac fossa, it's an obese recipient, and then this worked fantastically, and post-operative outcome was very good. The patient's creatinine was 0.96 at the end of a week time. There was no delayed graft function. This publication has been accepted recently in the Urology Gold Journal. Now, case 2 is that we had a 1-year-old pediatric donor, deceased donor, 1-year-old. So we procured the kidney and blocked the suprarenal vena cava and suprarenal aorta were sutured block. So the infrarenal aorta and infrarenal vena cava were available for the anastomosis, and both the kidneys were kept en bloc. Now, because we wanted to put the two kidneys into the iliac fossa, and it is sometimes difficult if we anastomose with the external iliac vessels, then probably one of the kidney has to remain intraperitoneally. So then there are chances of torsion of this, because the right kidney will remain on this side and left might remain on this side, then it will be a problem. So we thought that we should go with the common iliac. This is the first case report of its own kind in the world literature. We have not reported yet. So we went to the common iliac vessel. Here on this side, in this case, the right common iliac vein is on the right side of the right common iliac artery. Now, the peritoneal flap has been generated to accommodate one of the kidney, and of course, the cecum has been mobilized to accommodate the second kidney. Now, you can see both the kidneys are placed, and here you can see the aorta, which is close by. Here is the vena cava, the suprarenal vena cava is closed. This is the left renal vein, left renal artery, and other things are not seen. This is the aorta, and aorta ends here, and these are the ureters. Both the ureters entangled together. The distal end of both the ureter were anastomosed on the bench, and so that we can do only the one ureteric reimplantation. Now again, the infrarenal vena cava is anastomosed with the common iliac vein, and this is the completion of anastomosis, and this is the completion of the aorta is anastomosed with the common iliac artery of the recipient. What you are seeing here is the origin of the inferior mesenteric artery of the donor. It's a pediatric donor. We just ligated. And posterior to that, there are several lumbar arteries that also had been ligated. Any small other unnamed artery which is there, that also been ligated. So this is how we finish the anastomosis of the aorta, infrarenal aorta. Once it has been opened, like you can see the completion of anastomosis. After the opening of the clamp, both the kidneys which were flushed and they are engorged because of the edema, and you can see the bleeding point has to be checked, because often on a bench surgery you do not know in a cadaver that what is going to bleed. So all these things is to be secure by the taking proline stitches if they are small bleeder, and you can confirm that this is the vena cava, suprarenal vena cava, which is full, nicely drained. Then after, I could not show the artery in the picture, and these are the two ureters full of the urine because they are draining urine. Now, in this case, it was a small kid, and then the ureter were not reaching up to the bladder. So the bladder was dropped and mobilized, and the psoas hitch was taken. And then after the ureteric reimplantation has been carried out, just a single stitch has been taken to cover the anastomotic side, because we cannot do the detrusor tunneling because there are two large ureters, and it can compress the ureter and may cause the functional obstruction. So this is how the anastomosis is finished, and we make a suction and other things and then come out. Like this is the final picture of it and of the transplantation. Now we retroperitonealize both the kidney. This is the one kidney, this is another kidney, and just we put few clips so that ultimately it will be retroperitonealized so that it doesn't get torsion later on. And thank you very much.
Thank you, Pranjal. Thank you, Pranjal, for wonderful demonstration. And I must say this must be a difficult case. You have done so well. And it showed that dual transplant can also be done robotically. And I have done dual transplant, but open surgery. I have also used that pediatric same technique in open surgery, but not in the robotic surgery. So with that, anybody wants to ask any question?
So one thing is there that the transplantation by robotic route is becoming slowly popular. Obviously, as of today, there are many concerns which are there, and the speakers have rightly pointed out the concern. Now, I want to ask one question to Pranjal.
Yes, sir.
Is that you said repeatedly about the torsion of the kidney. Now,
Yes, sir.
when you do robotic transplantation, how frequent is this problem? And do you think that it is a real concern? That is one. And secondly, as it was commonly said that if you do robotic transplantation, then the lymphocyte incidence would obviously become zero because you already treated the lymphocyte. Do you share that experience or do you approve with that point? So these are two questions before we wind up.
Yes, first question, sir. I used to do the laparoscopic kidney transplant initially, and I used to take the peritoneal flap and cover it. In 2010, we had a workshop here, and we invited Professor Lloyd Ratner here. And he is not only doing kidney transplant, he's doing kidney and pancreas transplant. So he suggested to me that there is no need of fixing the kidney, because when we do the pancreas kidney transplant, pancreas is on the left side iliac fossa, right side iliac fossa, kidney is on the left side iliac fossa, and we never see the torsion. So I stopped fixing the kidney. Unfortunately, after 36 or 37 cases, there were 2 cases of a torsion, and that also delayed torsion. Almost 1 month after the transplant, patient went and then they came with the acute anuria, and then both grafts were lost. So since then we realized that the torsion do occur and there is a need to fix the kidney. So then in laparoscopic kidney transplant, we always used to do, I have done 177 laparoscopic kidney transplants. Subsequently, we never faced that problem. And that the same method, lesson learned from lap kidney transplant, we continue in robotic kidney transplant. The torsion occurs in a clockwise direction if you see from above. That means the upper pole moves medially, and that is the reason why upper pole has to go behind the cecum to avoid the torsion. And then we never found, now I have finished 515 robotic kidney transplant. We have never seen even a single case of a torsion now. So that is very important. The second question is about lymphocyte. Yes, sir, since the lesson learned in open kidney transplant are minimum dissection of the artery, the external iliac artery or common iliac artery, wherever you do the transplant is very important. If you do extensive burying of the artery, the chances of lymphocyte are there because there are damage to the lymphatics, or you use a cautery instead of ligating it or clipping it, there is a chance of the lymphocyte. So first and foremost is we ligate everything. I mean, we do the minimum dissection, and in case of extensive dissection is there, we clip everything. Second, in a bench side, on a bench side, I dissect a long artery and everything in the hilum I ligate it with the silk suture. So then the lymphocyte is contributed by both donor and recipient. So both sides you are blocking it, and then after you do the transplant, probably the lymphocyte incidence is less. And finally, it is a transperitoneal transplant by and large, because the lower pole is always exposed, and whatever lymph is generated, it is already fenestrated, and then it goes and absorbs into the abdominal cavity. So in my series, I do not find even a single lymphocyte till date, fortunately, touch wood, and that may be the reason why this is a preferred method.
Okay, Prasun wants to make a comment.
I have a comment to make regarding the extraperitonealization of the graft kidney. Not only does it prevent the torsion, but also if you leave it floating freely inside the peritoneum, subsequently when the gut moves in and covers. If you look at Jyly's series from Chicago, they had to do 7 open post-transplant kidney biopsies because the gut was all over the kidney. So it gives you a very happy nephrologist if he's able to take a graft biopsy if needed in the subsequent period, if you extraperitonealize and fix the kidney to the abdominal wall. So that is another big advantage of fixing the kidney apart from the torsion.
I have one question. Yeah, my one question to both Prasun and Pranjal. So what is you both have done large number of cases. What is the contraindication? Like what case you will not do robotically?
Yes,
both
sir. I think
Pranjal answer that.
Yeah, large kidney, autosomal dominant polycystic kidney, say for example, it's very large and you have not done a pre-operative or pre-transplant nephrectomy because there is no indication of nephrectomy, then it may be difficult. But if it is especially if it reaches into the pelvis, it is not indicated. The major lower abdominal surgery, maybe like Vardyne's or something has been done in the past, or in a female, or maybe in a very major surgery done in the male patient, then it's also contraindicated. Or laparotomy done for perforation or something like that is also a contraindication, because you are going to deal with a lot of adhesions. and there is no meaning of going for such type of cases. Best is to open up and do the straightforward transplantation. Other than that, like some COPD patient who keep on smoking, and then there is a very less reservoir, which are a general contraindication for laparoscopy itself, or when there is a uremic cardiomyopathy where the anesthetist refuses not to give this thing, or there is a hypertensive retinopathy grade 2 or 3, glaucoma. All these are the general contraindication for the transplant. Trendelenburg position and transplantation. So in those cases, we do the open kidney transplant.
Right, Prasun, you want to say something before we
add to what Dr. Pranjal said? One is an active atherosclerosis disease. If you can identify that, please don't do it. The second thing is small children. Like if you can assess on table that the robotics arm will clash, there will be difficulty in putting the kidney in. So small size babies, don't do it to start with. Two more indications that I would add.
Those are, I think, reasonable contraindications. But I think the whole objective of this particular session was to stimulate the people who are doing robotic and those who have transplant the workup going on in their institute, to stimulate them that this can be done. And as Pranjal has very rightly demonstrated, that even the most complex case can be done very successfully by the robotic surgery. And as people gain more and more experience, people will become more and more comfortable, and they will start digesting the fact that robotic transplantation is a reality, and it is not just the fashion, but it helps. So I think that with that note, we wind up this session. We were given 45 minutes, and we have exactly finished our session in 45 minutes. So over to you, Pranjal. Thank you very much for involving me in this session.
Thank you very much, sir. Thank you so much for moderating the sessions, and thank you to all participants also. Just I am asked to give the message. The message is very clear that what is not done robotically, we do not know. Just a few hypospadia surgeries, and the penile surgery may be like which are superficial. Rest of the things can be done robotically. Maybe the microsurgery has already been introduced robotically, like vasovasal anastomosis, vasoepidermal anastomosis. Ablative surgery like adrenalectomy and other things have already been now, and everything is done robotically. So it's an expensive way, but I think the India has progressed very well, and the future, present is robot, and the future is going to be the robot. And maybe like the telesurgery, maybe the future one can operate from one place to other, transatlantic, people are trying, and so many other things can happen. And I think if that is happening, what is the best part? Like say, for example, if we have a emergency in the night hours, a kidney available, then the surgeon from New York can operate here. I don't have to remain whole night awake. And during daytime of India, like we can operate over there somewhere in a United States, and that is not going to be far. That is my vision. Maybe in next 5 to 10 years, everything will be changed. The world will be a small village, and that is what the robot about. And I'm very optimistic about the robotic operations. Thank you very much, and over to Dr. Rajiv TP.
Thank you, Pranjal. What a wonderful semi-live webinar on the application of robotics for handling various advanced urological procedures. And all these speakers have done an excellent presentation, and this depicts how far the Indian urologists have gone in the field of robotics. As you have told in your take-home message, Indian urologists have done everything in the field of urology except hypospadias repair and the repair of stricture urethra, in fact. And one doesn't know in the days to come whether you will apply robotics there also. And I hope, and it shows that how far the Indian urologists have gone ahead, and we are at par or even much better than the experts in the Western world. And thank you all the faculties for their excellent presentation. I, on behalf of USI and Indian School of Urology, would like to thank all the eminent faculties and the experts for sparing their valuable time and doing a wonderful job. I also thank on behalf of USI and Indian School of Urology, the viewers from India as well as from other countries for being with us. We had a good number of viewers over the Facebook as well as YouTube channel. And we are this time streaming using a special software over multiple platforms. Thank you all once again. Good night.
Thank you very much.
And I also like to thank Navneet and Kiran Arora for the extensive support. They have been behind all these things for a flawless webinar, in fact, and from the start of later part of April till now, we have seen the USI has gone way ahead, because most of our webinars are quite flawless, and it is because of the logistic support rendered from the central office. And I also thank the Indus Pharma for the support they are giving us for all these webinars. Thank you all once again.
Thank you, everyone, and good night.
Thank you, Dr. Rajiv. I will like to inform everybody that the Indian School of Urology is celebrating Prostate Month, that is September, and block your dates on 11th, 12th, and 13th. Don't commit anybody, any companies. We are going to have comprehensive program, USI, and 11th, 12th, and 13th of September. Thank you.
Thank you. Thank you again, everybody, and good night. Good night.
Thank you. Good night.
Thank you. Good night, everybody. Good night. Bye-bye. Thank you.
Good night. Okay, good night.
जितेंद्र कुमार को फोन किया जाए।